All right. Are you going first or am I going first? Okay. Good morning, everyone. I would like to call to order the December 10th Virginia Board of Health meeting. This meeting is being conducted in a hybrid environment and is being recorded. There are several things that we would like to review before getting started. The names of all the board members, along with the constituency that they represent, are displayed on the screen. Several board members are participating virtually. Their names will be reflected in the minutes. In addition, there are several staff members from the Virginia Department of Health and the Attorney General who have physically assembled at the Perimeter Center in Henrico for this meeting. Consistent with public health recommendations, they will be wearing face coverings and sitting 6 feet apart. The list of all staff participating in this meeting is displayed on the screen. Some are participating virtually. For those of you who are viewing us virtually, we are sitting in pods a minimum of 6 feet apart, and I will sometimes take down my mask when I speak on the microphone. Lastly, today, all votes that are taken by the board during today's meeting will be roll call votes. I will be restating the names of the members who make motions or seconds. Attendees, you will not be able to unmute yourselves. When we get to the public comment period, you will be unmuted by the host if you have signed up to speak. With that being said, Ms. Jansen, please call the roll.
Thank you, Madam Chair. Mr. Kreitzer?
Here.
Thank you. Mr. Edmondson?
Here.
Thank you. Ms. Green, I know, is not able to join us. Ms. Hines?
Here.
Thank you. Ms. Harrison? Dr. Jang? I know is not joining us. Dr. Kinzer, I know, is unable to join us. Dr. Klein? Thank you. Dr. Miller? Thank you. Ms. Pritchard?
Here. Sorry.
Thank you. Dr. Puritz? Thank you. Ms. Ramos? Thank you. Dr. Schuler?
Here.
Thank you. Dr. Swartz?
Here.
Thank you. Ms. Whipple?
Here.
Thank you. Madam Chair, we have a quorum.
Thank you. And I believe Ms. Harrison will be joining us in person, but a little bit later. Thank you. All right, Ms. Jansen, would you now review the agenda for today's meeting?
Absolutely. So on the screen, you'll see the items that are on the agenda. So we have done our introduction and roll call, followed by this review of the agenda. We will begin with our approval of the September 2nd minutes, followed by the commissioner's report and a regulatory action update. We will then take a short break and then have a special lunch presentation from Alexis Aplaska from the Department of Behavioral Health and Developmental Services regarding behavioral health updates during COVID-19, and then have our public comment period. As a reminder, for our public comment period, it is not a back and forth question and answer session with the board, and we will be calling people 2 at a time. They will the person who is speaking and the person who will be on deck, and they will have 2 minutes each to provide their public comment. Next slide. We will then turn to our regulatory actions for today's meeting, beginning with the emergency amendments to home care organization regulations, and then proposed amendments to the disease reporting and control regulations, followed by fast track amendments to sewage handling and disposal regulations, and finally, final amendments to regulations governing the Virginia newborn screening services. We will then take another break. Next slide. And then we will have a presentation on the Board of Health's annual report and an update on the plan for well-being. And then Mr. Hilbert will provide a brief update on the 2022 proposals for the General Assembly session upcoming. We will finish with any other business and then we will adjourn.
Thank you very much. All right, it is now time for approval of our September 2nd, 2021 minutes. I trust that you have had an opportunity to review those. Let's get a motion on the floor, and then I will call for any discussion. Is there a motion to approve the September 2nd minutes?
This is Linda Hines. Move to accept.
I am so sorry, Sue. The motion is Dr. Schwartz and the second is Ms. Hines. Is that correct?
Yes.
Okay, Thank you. So we have a motion and a second. Is there any discussion or concerns? Jim? I believe that is not the case, but I will ask Norm to confirm. Yeah. So we couldn't have if we needed to, but we didn't need to. Okay, thank you. All right, that being, any other questions or comments? All right, then could we have a roll call vote? Alex, please?
Yes, Madam Chair. Mr. Kreitzer?
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Hines?
Yes.
Thank you. Ms. Harrison is a hold. Dr. Klein? Thank you. Dr. Miller? Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Puritz? Thank you. Ms. Ramos? Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Swartz?
Yes.
Thank you. Ms. Whipple? Thank you. Madam Chair, the motion is 4 ayes.
Thank you. All right. Before we move on to the commissioner's report, I would like us to be the board we usually are. We have two members, we have two new members today that we are very happy to have here. And I know we have Maribel Ramos here in person. Do we have our other member virtually? No, okay. Our other new member is in New York accepting a Woman of the Year award. So we will introduce her with lots of gusto when she's here next time. But Maribel, would you mind just introducing yourself and saying a little about who you are and where you come from?
Focused on health and human services for the past over year now. We've been really working heavily with states on COVID-19. So again, happy to be here with you all.
Well, welcome. We're happy to have you with us. All right, Dr. Oliver, it is now time for the commissioner's report.
Thank you, Madam Chair. It's always a pleasure to be able to present the update on public health matters to the Board of Health. Before I get into the substance of my report, the first thing I wanted to do was just publicly recognize 15 VDH employees, if we go to the next slide, who have at least 45 years of service to VDH in the Commonwealth. These 15 employees have been really remarkable. They're from many different regions from around the Commonwealth, and some of them also here at our central office. The commitment of these folks, I think, is just one particular example of the kind of commitment that we see across the VDH employees and staff. The last 2 years, as you might imagine, has been quite an intense period of activity 24/7 virtually for everyone in the agency. And I think their commitment is what keeps them coming back. And I think it helps to explain the kind of resilience that we see in VDH. Next slide. I want to spend a few minutes providing you with a status report concerning our public health transformation roadmap. I gave a little bit of a presentation on this at the last board meeting. What do we want Virginia's public health system to look like in, say, the next 5 years? This is what this roadmap is all about. We began this effort in August, and we spent 4 months pulling it together. And it was an effort that was not just VDH, but multiple stakeholders. We can go to the next slide. We pulled together stakeholders from other state agencies, from community organizations, from academia, multiple universities, from industry, Google and others participated. We had healthcare providers and agencies like MSV and others participated in it. And the transformation roadmap that we put together is based on these 5 principles here. We have a consistent mission. We promote equitable health outcomes and collaboration with our community partners. The partnership is key to everything that we want to do in this transformation of the public health ecosystem. And as I said, equity is something that will run throughout all the initiatives that we carry out. It's going to be action-oriented and realistic. We want to have initiatives that we feel we can achieve in the next 5 years, and we're looking for lasting changes. So we want this to be sustainable. Next slide, please. The pyramid here in this little cartoon shows the essential services of public health on the inside, and our mission there at the apex. Around the edge, you see equity and partnership is something that is required for all of these services to be effective. Underlying this is the public health infrastructure. I made the point that the transformation roadmap that we're laying out is not about changing the mission or the services of public health, but it's about building back the public health infrastructure. They're represented by those pillars of data and technology, our organizational structure, facilities, communication, and other things that you see in those pillars in the bottom. One of the things that we saw and others saw in the course of our response to COVID-19 is that there were gaps in our public health infrastructure. Gaps, for example, in our data reporting, our data analytics, gaps in our capacity around communication and other things. And we want to fill in those gaps and build even stronger infrastructure going into the future. Next slide. So all of these stakeholders over the 4 months developed 4 overarching sort of strategies for this transformation in the public health ecosystem, developing a shared holistic foundation of knowledge for public health, expanding community reach by investing in diversified talent, addressing systemic challenges through a unified approach, and building trust with communities through tailored messaging. For each of those strategies, we then developed a number of initiatives. There were 4 strategies. We developed 10 initiatives, and each of those initiatives have associated with them a number of projects, and we came up with 35 different projects. Next slide. So in each of these strategies, we have some actions that we want to carry out. And these actions are really aimed at, as I said, implementing these strategies in a real way across the Commonwealth. Next slide. Through the public health transformation, we will address these challenges here. The chronic underinvestment in public health departments. We will look at and resolve this issue, this challenge of fragmented data and technology infrastructure in public health. The third one there, eroding trust. While we believe that the majority of people have responded well to the public health messages, and as you can see with our vaccination status here in Virginia, has really come out and responded well. There is some pessimistic outlooks there that we need to address and really build trust even better in public health. We want to address the inequities in health access and outcomes. We saw this before COVID-19, but COVID-19 really highlighted these inequities in a much more stark sort of fashion. And we also want to address the fractured ecosystem with all of its varying incentives. Again, addressing the issue of getting really sustainable funding for public health. I believe that we circulated to the board the transformation roadmap, so you got a copy of that and you can take a look at that. And if you have questions on that going forward, we're happy to answer that. But now I want to move into the COVID-19 pandemic and our response to that. We'll talk some about the disease burden. We'll talk about testing, containment, communications, and the vaccination campaign. Next slide. So we released a news release yesterday. We have our first case of Omicron in the Commonwealth of Virginia. It wasn't, it didn't spring up here, or it was related to a conference in New York State where there was a little outbreak of it. And one of those cases is here in Virginia. That being said, we can expect to see many more coming. As you know, on November 26th, the WHO designated this virus, Omicron, as a variant of concern. The CDC then designated it as a variant of concern inside of the U.S. Earlier this month, on the 1st of December. Viruses, as you all know, constantly change, constantly mutate. Sometimes the mutations are meaningless and no one pays any attention to it. Other times they become concerning because of characteristics in those mutations, and that is why Omicron is of concern. It has a very high number of mutations. Some of these mutations are concerning because they're on the, you all have seen the cartoon of the coronavirus with all those spikes. So the spikes are the things that our antibodies use to get rid of the virus, and the antibodies that are generated by the vaccines also use those spike proteins as their attack point on the virus. So these mutations raise a concern that perhaps this variant of the virus could escape our immune system's protection from vaccination or infection and make it able to spread faster from person to person. As you know, it was first detected in Southern Africa and South Africa and Botswana and other countries in Southern Africa. Since then, it's been detected in more than 20 countries around the globe, and those are the ones in the lighter orange. The dark orange shows the first reported cases. Coming out of South Africa right now, the preliminary information shows that Omicron spreads quite rapidly. We do have to take into account that there's a big difference, however, in South Africa and countries like the U.S. The vaccination rate in South Africa is something like 25%. So we don't know how it would go here in the United States or in the Commonwealth, where Delta is still the main variant. Next slide. A number of countries have instituted some travel restrictions. Travel restrictions don't really stop viruses. It's maybe slows them down a bit, and that was the intent, to give us all some time to prepare for this new variant, get some more information from studies in Southern Africa and in Europe, and be able to have some idea about its transmissibility, the severity of the disease that it causes, its impact on vaccine effectiveness, its impact on therapeutic, on the effectiveness of therapeutics, which also need those spike proteins, as well as on diagnostics, and whether it might become problematic to detect this variant. As it turns out, one of the genes that this variant dropped out means that it can still be detected on a PCR test, but the PCR test picks up this gene dropout. So it's a marker for Omicron. It's also a marker for one other variant. So when we pick up that gene dropout, what we can then do is, we need to take that sample and do a gene sequencing to see if it's Omicron or the other variant. Here you see all these key points of regarding our response. We really ramped up our international traveler monitoring response to, the other day there were close to 1,800 or so folks coming in through through Dulles, but there were only 4 of them from Southern Africa, from the 8 countries that have been where we have the travel restrictions. So, but we're monitoring that, reaching out to people who come from those countries in order to do the appropriate sort of contact information with them, tell them how to go about quarantining for a full 7 days, getting testing 3 to 5 days after arrival, and giving other guidance, and then just monitoring them to ensure that they don't have Omicron. At this point, there's no written CDC guidance yet, I believe. So it remains unclear how long this approach will be utilized, and how extensive the Omicron spread will be in the U.S. We'll continue to send some informational emails to all of these international travelers, as well as home test kits. These are the PCR test kits. And we call them and check on their health status, as I said. So that's it on Omicron. If we can go to the next slide. This is data from a week or so ago. If you've been following our website, we've been doing it at larger, at weekly sort of time intervals. This slide says that Virginia has an incidence of about 117 cases per 100,000. That was true a couple of weeks ago. It's now up to 168 per 100,000. It's been increasing for the last few weeks, and increasing rapidly. It's increased this last week by about 40%. If you look at our daily numbers, our case incidence is around 3,000 a day now, which is not as high as it was in January of this year, but it's as high as it has been any time other than January. It's really quite concerning. And Christmas coming up, I think, will mean probably more cases will come about. If you look at that map, you'll see that we have very high incidence of COVID-19 in the northern states. And in addition to all the family gatherings and so on over the holidays, this would sort of indicate that perhaps COVID is acting like a seasonal sort of disease, and winter could be a problem, right? So the coldest states are having the high incidence, and it's been marching down from the north as a result. So we've been tracking below these northern states. And we're tracking better than a number of our surrounding states. So that's good. But if you go to the next slide, we still have a situation where the Commonwealth has a widespread high level of community transmission. Again, this map is from a couple of weeks ago. The map today is all red. Every single region is in high level transmission. Next slide. Along with the cases, we have seen an uptick in hospitalizations and ICU usage. And there's even been a little bit of an increase in the deaths that have been recorded. Next slide. Our test positivity has also been increasing, indicating that there's a real need for us to increase the amount of testing that we do around the state. Antigen tests have picked up a lot, and we've had some programs where we've been really pushing the use of these antigen tests. And on the next slide, you'll see one of the ways in which we've done that. And it's through this program supporting testing access through community collaboration. These are the tests that we're providing here are proctored at-home antigen tests. They're given to community members through local libraries. We did this based on a successful program in Ohio. We launched a pilot of this in mid-November at 18 library systems. And as of December 1st, we have 41 library systems. So that's many libraries, right? Because it's whole library systems that are getting these test kits. And we've shipped about 30,000 test kits to them. It's a really innovative partnership, and we're looking at other ways to build on these partnerships. So for example, in Washington County, the libraries were able to pair these testing kits with a mobile vaccine unit right there in place. And in Fluvanna, we partnered not only with the libraries, but with local churches, which helps seniors navigate the technology and offer use of the Wi-Fi in their parking lots.
Dr. Oliver,
Yes.
I read it that in Fairfax County, they had tests available at one of the libraries and they were gone within the hour.
Yeah.
So that means, pardon me, demand is quite high.
What was that?
Demand, sorry.
Is the demand high? Yes. Yes. If you want to talk, if you talk, we won't mind if you pull down your mask to say a few words, because it's really hard to breathe and talk to these things.
So I would
Yes,
just.
the demand is quite high. And it's one of the ways that we hope to increase the amount of testing that's going. We need to do that with the increased incidence of the disease and with the advent of Omicron, which will probably be growing in incidence here in the Commonwealth. We need to get back to that containment paradigm of boxing in the spread of the virus, right? Testing a lot so that we can identify cases early, isolate those cases, find out who their contacts are, quarantine their contacts, and in that way we can sort of box it in and slow down the spread. Of course, the best thing to do is get more people vaccinated. One of the things I didn't mention about the Omicron that's news that's been fairly recent is it's fairly clear now that being boosted gives you added protection, not only against Delta, but against the Omicron as well. So getting people that initial series and then getting them boosted is our best option.
Dr. Oliver, if I could just for a second, since we're on these new microphones, I am a little bit hard of hearing, but I can't be the only person in this room who's struggling a little bit. So if you're going to speak, pull your mic just towards you a bit so that everybody can hear, because I think, Mary Margaret, you're the farthest one from me, and I'm struggling to hear you just a little bit. So, and then I think Ms. Ramos had a question.
I just had a quick question, Dr. Oliver. Are you seeing a shortage of testing here in Virginia? Of tests?
Of supplies?
Mhm.
No, it's not. It's not an issue of shortage of supplies. There was earlier in the fall some issues with antigen tests not being available, but that's pretty much resolved now.
Hi, Dr. Oliver. This is Linda Hines. If people are looking to where they can go to get the test, I actually had to get a test on Wednesday, and it was a little challenging because, of course, most everywhere needed an appointment, and I had thought that I had an exposure, so I needed to get something done pretty quickly. When I finally did get an appointment, I waited about 2 hours to actually get the test. I mean, are there just walk-in sites, and how do people find out about those?
I believe that the best way to find out by testing is through, we have on our webpage, there's a place you can go and find testing sites. And that would be one way in which to do it. Pharmacies are offering it. Lots of physicians' offices and so on. And the hardest ones to get have been, and I think continue to be, the antigen tests. The libraries, like in Fairfax that ran out, we only had 30,000 kits that we gave to all those 41 library systems. So 30,000 kits gets eaten up pretty quickly. So we will, we intend to expand the program and provide more, but it's just one channel in which to do those, get those tests.
Dr. Oliver,
next
can I
slide.
add a comment?
Yes, go ahead.
I did place the link that you just referenced on the chat. And so, what we're likely going to see is cases increase over the next few weeks and a couple months in the cooler climates. There's an increased desire for testing. And so we have encouraged the local health departments to host what we call a community testing event, one before the holidays and one after. And so many are beginning to do that. Some offer it through the local health department. And this is going to be one of those things we're going to have to look at as we transition from kind of an emergency response to the continued fact that COVID is here to stay. And similar like the flu and others, it's a matter of making sure people have access to healthcare, access to testing. As you may know, a lot of the pharmacy chains now provide testing over the counter. So you can actually take it, and I did it for my wife just the week before she wasn't feeling well. The challenge with those is the reporting and official. If you need verification for the TSA or others, it's best to go then to a provider or to a pharmacy to get it done where they are being provided. But I think what we're beginning to also see is really making the testing response a part of our kind of everyday healthcare service that just doesn't necessarily need to be provided through public health. But again, I think the program Dr. Oliver just spoke about with the libraries, that's just a brand new pilot, and we're beginning to already see really, really promising signs. And so I think we're going to see a significant expansion of that, where we could be strategic in certain communities, including vulnerable populations, where we could provide these tests for free if the libraries are willing to host that effort and share it, with their population. So again, point being that yes, it's not always 100% easy to at-home tests and over-the-counter tests are really proliferating. And then just the last little bit, we're also going to have to see how Omicron is going to impact testing, because already with a couple of the tests that target the specific gene that is now mutated due to the Omicron, those tests may not be as efficacious. So it is probably going to be something that we're going to continue to look at and ensure that the tests that are out there are meeting the citizens and the community's needs.
Thank you, Dr. Jabari, for those comments. That was very helpful. Dr. Jabari, for those who don't know, is the Chief Deputy Commissioner at VDH and is in charge of our Community Health Services, which is the division of that is organizes all of our 35 health districts around the Commonwealth. Any other questions from members of the board? Okay. Well, then going on, I wanted to say something about another testing program that we have. VISTA was a program that was initiated through funding from the CDC. And we have 56 public school divisions and 25 private schools that expressed interest in being part of this program. These school divisions comprise about a little over 1,000 school campuses and about 650,000 students and around 87,000 teachers and staff. Our K-12 testing team has been facilitating calls with all of these interested schools and local health districts, collecting data and information through surveys to confirm their commitment to the kind of populations that they're going to test, testing schedules, start dates, and the resources that they would need for that. We put out an RFP for vendors to will be then charged with conducting pooled testing in the schools. And I think this, and Dr. Jabari, you can correct me if I'm wrong, I believe this started just this week, and a number of school divisions. We do have some existing vendors who can do this work, and so already we had 12 school districts that had been matched with these existing vendors, and when the other vendors come on, they'll be doing this. As Dr. Jabari mentioned, the local health departments are helping to support these schools, and they are also supporting them through the community testing events that Dr. Jabari mentioned and highlighted. Yes.
I'm really encouraged that in particular, so many of the districts from the Northwest down to the far South have committed to this VISTA program. Do you have any sense of whether with the change of administrations in the state, there will be feuding between elected officials and school board members, also elected but separately, over the intention to participate in VISTA?
So participation was voluntary, and I believe from things that I've heard from just news reports and so on regarding Governor-elect Youngkin's views around these things, that he's stated his opposition to mandating things, but this is not a mandate. And the school divisions that have opted to participate in this have done so on a voluntary basis. So we'll continue to reach out, provide opportunities for other school divisions to join in, and I would expect that to continue.
Dr. Oliver, if I could just add one more sentence there. What's interesting, what we're hearing from our local health directors is while there may be some concerns around the mask mandate, the districts, regardless of kind of where they are in the geography of Virginia, are actually generally supportive of testing. And in some cases, such as Chesapeake and Virginia Beach, where we've been talking about some more recent guideline considerations, while they may be looking at reduction in the number of days for quarantine or potentially rolling back the mask mandate, they're actually very supportive of testing and see this as a tool that can help them justify why masks aren't there. So it's an interesting irony that for the testing, we seem to have really strong support. I think what prevented some of the schools from initially signing on is that additional manpower, right? So you get more information, you got to do the follow-up. There's the whole containment piece that follows. But, this did start some weeks ago, and we're just continuing to see it expand. And so far, I guess my point is that we've really seen broad support for those school systems that have implemented this strategy.
Okay. Thank you, Dr. Jabari. Let's go to the next slide. As I said earlier, testing is the first part of this containment effort involving testing and case investigation, contact tracing, monitoring, and so on. The key thing here, of course, is detecting people with COVID-19 who are infectious as soon as possible, and then isolating them and quarantining their contacts. Today, we have 1,083 staff who are supporting our case and contact investigation efforts in the local health departments and on some regional teams that we've established. Earlier this year, VDH worked very rapidly to expand our case investigation and contact tracing workforce due to the rising numbers in the Delta variant. You may recall that in the early summer, cases went way down. There were days when we had less than 100 cases in a day. We had ramped up our case investigation contact tracing workforce prior to that, dealing with the earlier surges, and some of that workforce, we lost through attrition or shifted them to other things. So we had to build it back up in the summer because of Delta. We partnered with the Institute for Public Health Innovation, IPHI, which some of you may be familiar with. And with their help, we were able to increase our case investigation, contact tracing workforce pretty rapidly. In the past year, staff have attempted to contact about 73% or a little over 600,000 reported COVID-19 cases. And 53% of all the reported COVID-19 cases had a completed case interview. So we actually spoke with them, not just reached out to them. Another major initiative that we undertook to help with containing the spread of COVID-19 was our COVIDwise app. It was an exposure notification app. We now have about 25% of folks in the Commonwealth between the age of 18 and 65 who have a smartphone have COVIDwise on their smartphone. So that's pretty astounding. It becomes a really powerful tool to help people with containing the spread of COVID-19. Next slide. One of the key things for helping us to manage this really massive amount of cases, just to give you an idea, before this pandemic, our disease surveillance system in a really busy year might see 90,000 cases that we had to follow up on. And so the data infrastructure we have for dealing with this sort of thing was built for that, right? And managing all of those cases and so on was a real challenge for us throughout the pandemic, because this was many, many times more cases. And so we had to, with the help of our just outstanding folks in our IT department and others, we built in some support from consultants. We built this system, Virginia Case Assessment and Management System, to help us. And we launched this earlier this year. And it allows case investigators then to really improve their efficiency in handling cases, tracking them, facilitating the assignment processes across districts and regions. It provides a virtual environment to do all of this work and bring all those teams together to be able to identify clusters and improves the data flow between our disease surveillance systems and the case investigation teams. Next slide. So our community mitigation team played a very essential role in working with our partners at the Department of Elections this past November to help ensure appropriate mitigation measures were in place to protect Virginians on and leading up to Election Day. They advised them on mitigation measures to protect volunteers and staff working at the polls. And it continues to do similar sorts of work in developing policies, procedures, and guidance for a variety of settings in public schools and businesses and other community venues. As this little cartoon here depicts, there's multiple layers to protecting ourselves from COVID-19. And one of those layers is mask wearing. It's a very important and essential part of the protection that we have against COVID-19. And it's something that we have kept in place for the public and private schools, K through 12. And our recommendations are for the general public is basically in situations where you're in a high level of transmission that people who are unvaccinated most definitely should wear masks, but all of us really should wear masks since we know that there is some breakthrough infections for those of us who have been vaccinated. And there's some indication that with Omicron, there may be even more breakthrough.
Dr. Oliver, if I could ask a question. I am continuing to face a fair amount of pushback in my own community about the efficacy of masks. Sometimes from people who are, frankly, one of my own board members who said, just a matter of opinion about whether masks work or not. You can smell through them, you know, the stuff. And I find myself more often than I would like standing in front of groups of people drawing pictures of molecule sizes. And I wonder if we might not rethink to some degree our communication method about masks, not just that masks work, but why and how masks work, particularly with things that we can target at K-12. You know, I remember that, I don't admit this gleefully, but I was once a smoker. And one of the reasons I don't smoke is because my then 8-year-old came to me and said, look what this is doing to your lungs, mommy. But we did such an effective public communication strategy around smoking. We do it with other things that I wonder if we just might not find better ways to communicate to people how masks work so that they actually believe that masks do work. Just a thought.
Very good thought. John, if you could do the next slide. Actually, the one after that. I believe that communications is really key. We have done a lot of communication, but I would agree with you that we need to step up our game a lot in the communication arena and on a number of fronts. If you picked up your phone right now and Googled COVID-19, first 5 hits you get would probably be garbage, right? There's a ton of misinformation, and active disinformation being pushed around COVID-19. And I think we need to work on how we do our messaging, and we need to work on our messengers as well. I love Tony Fauci, but I don't think Tony Fauci plays well in a lot of places. I think what we need is messengers who are trusted by the communities that they're presenting the message to. And in some cases, that's more important than the actual content of the message. I know one of our local health departments up in Loudon, I found they did a spot there with a I forget how he describes himself, but born again Christian, real fairly conservative pastor, but who supported vaccination, and had him talk about why, from his point of view as a devout Christian, this is something that you ought to do. And I'll guarantee you that had more impact on people that he was talking to than anybody we would have put into that radio spot. So yeah, we have to really step up our game there. One of the things that we did, for example, earlier this year was we started what's the business term? It's like market segmentation. But we looked at the fact that we were having a real challenge with the 18 to 40-year-olds, really low uptake of vaccination. And we went on a special communication and media campaign that was directed to that demographic. And we made some progress in that. So we do have to do exactly what you said, Madam Chair. That being said, we've done, like I said, we've done a lot. As you can see on this slide, we've gotten a lot of impressions from all the media work that we've been doing. We've done these satellite media tours. That's where I got one coming up next week. You sit there for 5 hours and you get one after another radio interview, newspaper interview, TV interview for 5 hours. And it's a very effective way of getting out across the Commonwealth in one sitting. We have Communications Hub, which is on our website, and it's a resource site. So people can go to the Communications Hub to get resources that they can then download and use in their local areas. We've done a number of town halls. The community ambassadors are people who sign up and want to help in spreading the message, and we've utilized them in a number of ways. Next slide. You can read through this on your own. We've accomplished a lot through these communication efforts. As I said, getting trusted messengers has been a particular effort of ours so that we can make sure that we're reaching these demographics that would be hard to reach otherwise, unless you had someone that they themselves trusted quite a lot. We have had a good deal of resources to put into this work. Our current communications budget, for example, has about 12.5 million in the governor's budget. We have through the CDC another 6 million in one of the CDC grants that we have, and we've spent or are spending about 6 million in coronavirus relief funds for the communication efforts. The next slide shows you some more accomplishments of our communication campaign, and you can just take a look at that at your leisure. Next slide. So we've administered more than 12.8 million doses of the COVID-19 vaccine. And as you may know, Virginia is in the top 10 of states in the U.S. in terms of the number of doses that we have administered, and for the percent of the population 18 or older who's vaccinated. Next slide. Yes. No. Is it?
Yes, okay. Sorry, before we leave communications, Faye, in response to you, I have one line that often will help stop anti-maskers in their tracks, which is if someone says masks are not necessary, my answer is, so I guess that means that if you're having surgery, your surgeon doesn't need to wear a mask in the operating room. People have no answer for that because it's counter to what they're saying. So that's a good line. It's a good comeback. The other thing I would like to draw to people's attention is there was a very excellent editorial in the New England Journal on digital health equity, because I think we have done an amazing job in Virginia, but I still feel like, I'm going to read a sentence here, many digital health tools are developed with homogeneous, highly educated, and advantaged populations in mind. I think that there has been a huge effort made in Virginia, but we still put too much emphasis on look it up online, go online. People don't understand when we use high literacy language. I have families that I help, they get messages, they get emails, they get texts, they don't understand them. We are still, I don't think, creating equitable digital access. So I would just like to get that on the radar.
Thank you for that, Dr. Klein. So we have, as I said, we're doing well in the vaccination campaign. We have about 78% or so now of the adult population that's fully vaccinated. So that's 18 and up. It's lower than that when you look at the whole population. The channels through which the vaccines are being provided, you can see here, the majority of vaccinations now are occurring through pharmacies, and our local health departments are doing quite a lot of them as well. And then you see the other channels as well. The role of the vaccine providers has changed over the course of the vaccination campaign. Early on, it was primarily hospitals and our community vaccination centers, but that has changed. Next slide. So if you look at this section of this graph in the red box there, you'll see that we've had an increase in the average number of doses that have been administered this fall. So we're heartened by this uptick. Some of that is represented by people coming for boosters, but there's also been some uptick in around first and second doses. It also represents our going out and getting the pediatric population, the 5 to 11-year-olds. Excuse me?
I have a question. What percentage would you say in that uptick in vaccinations recently is, in fact, people just getting boosters versus people who decide, okay, this thing is serious, finally, I'm going to do it, protect myself and others? Do you have any feel for that?
I don't have the numbers right in front of me, but I can get that to you.
Just curious.
The majority of it is boosters,
Mhm.
I would say, but there are people who, I think because of Omicron, have come out now to get their first dose. But
Okay.
we've also seen an increase in boosters, right? It's the same, for the same reason, people
Mhm.
wanting to get some extra protection. But
Right.
the actual numbers I don't have. Let's say somebody online somewhere who on this call who has those numbers in front of them.
Thank you.
Dr. Oliver, I had a quick question about boosters. This week, the FDA amended and authorized the use of Pfizer boosters for 16 to 17. What are the steps necessary, I guess, next for Virginia? Or is that something that's ongoing at this point?
So we were waiting for that from the CDC, and the CDC last night approved that and set out the when the CDC and the ACIP, the what does that stand for? The Advisory Committee for Immunization Practices. They set actual guidance for how you should deliver the vaccine. So that's all been done now. So we put out a news release today, and we will be starting the boosters for 16 to 17-year-olds as well.
Quick question. Can you comment on what you're seeing, what kind of uptake you're seeing in the pediatric population?
I think 5 to 11-year-olds, we have, it's on the next, is it the next or? So this, you'll see the breakdown there. We have about 23% of the 5 to 11-year-olds with at least first dose. And this is from a little over a week ago. So it's increased.
Right. I know it's very new. I just was wondering what the buzz was and whether people were showing up, bringing their children. And
I think it's been the sense that we've been getting, and Dr. Jabari, you might want to say something on this from what you've heard from local health districts, but the sense I've been getting is that the buzz is people want to do it, but there is some hesitation as well. So it's not a super rush, right? And it sort of reflects what happened in the adult population. So those areas like Northern Virginia, some of the more urban areas, there's been bigger uptake than in rural, South Side or far Southwest Virginia. Dr. Jabari, do you have any anecdotes from local health district directors with respect to that question, if you're still on? Okay, nothing heard. We'll just move on. On this slide, you can see that we've got very good vaccination rates in the older population. Take off my glasses to read this. So we have about 97% of 65 to 74-year-olds and 96% of the 74 to 84-year-olds. And that same sort of distribution can be seen in the fully vaccinated. We've been challenged in the younger ages. I think the pediatric population has been, we'll see how that goes. We continue to get uptake there. The real challenge has been in that, like I said, the 18 to 40-year-olds. Next slide. And this reflects what's happened on the boosters. We've been able to administer boosters to a little more than 30% of those who received the first series of the vaccine. And again, you see the same sort of issues across the age spectrum then on who's taking up that. And the older population has been better at taking it up. Part of that, of course, was that the CDC guidance on this changed over time. and it wasn't until recently that everyone 18 and older was able to get the boosters. Next slide. We recognized at the very outset of our response to COVID-19 that there were racial and ethnic inequities in how people were, first of all, on the impact of the disease, which impacted Black and Brown communities far more seriously than other communities. They had higher incidence of the disease, higher rates of hospitalization, higher rates of death. Through our whole of government response to COVID-19, we established what we call a incident command structure. So it brought together a lot of different state agencies and vendors and others that we were using to carry out our campaign against COVID-19. And there's a general command for that effort, that unified command. And then we have staff in finances and logistics and operations and planning that all work together as a whole unit to fight, to deal with the pandemic. Part of the command group of this structure was what we called a health equity working group. And the health equity working group was established to help ensure that in every aspect of the work that we did, we would do it with a lens on to really make sure that we were getting to the most vulnerable populations, looking at the racial inequities across ethnic groups, and also across geographies. So with respect to vaccination, one of the things we saw in the early part of the vaccination campaign, we wanted to ensure, our goal was to make sure that we were vaccinating, Blacks and Latinos and other minorities at the same rate that we were vaccinating the white population. And that was not the case early on. We were getting, the ratio was about 0.3 for Blacks and around 0.7 or so. Actually, it was also around 0.3, but it then quickly went up to about 0.7 in the Latino population. So we did targeted interventions to try to correct that. We really concentrated a lot on making sure that we got to those communities with the vaccination campaign. So to your point, Dr. Klein, we put emphasis not just on the digital stuff, but boots on the ground. We had teams of essentially like community health workers that would go into communities door to door, talking to people and that sort of thing. Did stuff at churches, at local bodegas, and trailer parks, whatever. We really made an effort to reach out, and it showed. By the summer, end of the summer this year, we were vaccinating the Latino population at about 1.5 times the rate we were vaccinating whites. We did not reach parity in the Black community yet, but we're at 0.9, which was a huge jump from where we had been. So it's important to recognize that the inequities in the way that the disease is, showing itself, right, with the higher incidence in those communities. And if that's the case, then we really have to focus and make sure that we appropriately respond with our countermeasures.
I'm just curious, with the Native American percentage being over 100%, is it reflective of some questions about the validity of the data?
I think the data's valid. The Native American population, it may be more like a denominator sort of problem. I know for a fact that we did do a just outstanding job in among the Native American population. A couple of our districts out in Three Rivers and Chickahominy district made a special point of partnering with several of the tribal nations to make that happen. I can look into that, Jim, and get back to you.
Yeah, it
Oliver, this is.
it jumped out at me when I was reviewing it before the meeting, and it's just, again, it's a level of curiosity. I don't want it to be used as an excuse to question the data.
So I did have that same question, and I do remember from last board meeting that the rate of vaccination among Native American population was very, very high, even then. So the other question I have is that given all the effort that's been made for, messaging that is tailored to the groups you're targeting, and you had so much success with Latino and Native American populations, is it a messaging issue with the Black population, or do you see strategies to help improve that percentage?
I think the key strategy goes back to what I was talking about and we were all discussing with respect to communication, having a good message and having the right messengers. We tripled the rate that we were vaccinating the Black community. So it worked a lot. It worked well. We didn't get parity yet. And I think that last bit may, in fact, represent some hesitancy that exists in that community. And we have to just keep chipping away. So I'm speaking later on this afternoon with about 400 Black pastors. And that'll be my pitch. They need to get out and really be ambassadors to help convince their congregations to get vaccinated. And if they've been vaccinated, to get boosted. And keep chipping away on it. Any other questions or comments from the board? Okay, John, next slide.
Dr. Oliver.
So
Sorry.
I'm sorry.
Sorry, Dr. Oliver. I think Dr. Peak was trying to add something to the previous slide.
Oh, excellent.
I don't know if she wants to unmute and jump in.
Dr. Peak is our state epidemiologist and the head of our Office of Epidemiology.
Good morning, everyone. I put it in the chat. The vaccine unit has looked into the issue of the percentage being greater than 100%. And it's a small population, so it is an issue with both the denominator not being exact, and then also when people self-report, there could be errors there. So the vaccine unit has looked at that, and they have followed up with local health districts that are affected and provided that messaging.
I just had one other question. In terms of reporting, it's very interesting to see the numbers by race, but I wonder if we could also at some point look at numbers by special groups. Of course, my thought goes to pregnant women. I am a broken record every day and an unsuccessful broken record every day of trying to convince my patients. And I wonder if tracking that and focusing on that wouldn't be helpful, because it is a very vulnerable population, and yet we don't seem to, I don't have good data. I mean, I have some data through ACOG, but I think that's a population that it has a lot of ramifications, and maybe we could get some information at that and see what we could do.
Might be something we could do through our partnerships with healthcare systems. You know, in the immunization registry, that's information we wouldn't necessarily have in the registry. So I think it means partnering with providers.
Yeah, just a thought. I mean, like I said, I could anecdotally tell you the numbers are low. It's not that there's a mystery out there, but sometimes tracking it and having a number to bring to people's attention, along with the number of deaths, because I find myself actually telling women that we've lost in our practice 2 patients, and why they cluck their tongues and are very sympathetic. It's amazing how they can then turn right around and go, that is so sad. Yeah, no, I'm good, but thank you. It's such a disconnect that it's really difficult. But I just think that sometimes seeing numbers, even of deaths, unfortunately, or ramifications may prod that population to follow the recommendations.
Thank you for that suggestion. Yes. It's got to be bright.
There we go. Oh, sorry. Do you have a message, or is there a message on the website or resource that we can use for younger people to try to reach them, to encourage them to get vaccinated?
Yes, so I mentioned the communications hub. If you go to our communications hub, you can download resources that we did a very targeted campaign towards that age group, and there's resources there that you could get and utilize.
So how do you get to that communication? Yeah. Okay. Thank you.
And I'll compile the links or these resources that we want to share, and I'll make sure that we send out an email to the board after the meeting with that information.
Thank you, Alex.
Madam Chair, just on the communications sub, just to remind the board that following the September meeting, and Dr. Purich made a lot of good comments in September, we made that site publicly available to a wide range of our partners, healthcare providers and others. So, but yeah, we will get that information out further here.
And that was very helpful. So thank you. It really did make a difference. Appreciate it.
So with this slide, I just wanted to remind you of the various vaccine strategies that we've used in this prior quarter that really helped to get Virginia to where it is today. It was the community vaccination centers or mass vaccination sites that we've called them in the past was one thing, but community partnerships and targeted clinics really helped a lot. The mobile clinics and the call center was a really great aid in directing people to places where they could get vaccinated. On the next slide is where we talk about the targeting of particular demographics, the Black community, different age groups. Rural community, we did a lot there as well. And I already talked about what we did in the Latino community. Yes, Dr. Klein.
Can you tell us a little more about what's a precision pharmacy? And tell us a little bit more about the mobile clinics, where they're being used. I would love to hear about that.
Okay, I'm gonna call in a friend. And Dr. Peak or Dr. Filano, if you're on the line, you could talk about those. The question was getting a little more information from someone in the vaccine unit about our precision clinics and what those are and what where we've been sending the mobile clinics.
Sure. I'm not sure if Dr. Perlon is on. She could speak to this.
Okay.
But if not, the precision clinics are just smaller the districts looked at their data to understand where there were gaps in vaccination and worked with vendors or sometimes on their own to set up targeted clinics to meet those needs. I don't have the data for where those have been provided, but we can certainly get that from the vaccine unit and provide that to you if that's needed.
So they're kind of pop-up clinics where needed.
Yes.
Is that correct? Okay, thank you.
Great way to describe it.
Yeah, pop up but very targeted.
Thank you for that.
And the mobile clinics were utilized in the, primarily in a lot of the rural health districts, South Side, some in far Southwest, but other regions as well. And then they also, I don't need to tell you, I mean, even in the urban areas, there's places where people cannot, they're not going to go down to the big community vaccination center. And so in Norfolk and other urban areas, we utilized mobile clinics to get out to communities we knew we were not reaching through those sort of sites.
Well, I applaud all these efforts and I thank you.
Okay, John, next slide. This is just, I know, one after this. A number of things that that have happened that just to bring you up to date on number of initiatives that we've done to try to change the vaccine response. We updated our data tracker. We have improved the dashboards. I think you know that you can go onto the registry now and get a QR code to show your vaccination status. And then this just enumerates a number of these, like those precision clinics, Wendy, you know, we did 70 MOAs with pharmacies to be able to do that. So this shows a number of different ways in which we try to accommodate providers and others to get the vaccine out. That small shipment redistribution program that we initiated was a real huge help to community-based providers who, you know, they can't get a pallet of 1,000 Pfizer doses. There's no way they're going to use that. So we would get the doses and then bust up the pallet and make small batches we could send out to community-based providers, and it allowed us to, again, increase the spread of providers and channels for getting people vaccinated. You know, it is so true, Benita. We have an amazing team. The people in our employees in VDH, the frontline staff and all our health districts are absolutely outstanding. As I said earlier, they've been at this for 2 years now, basically, and they keep going. And in addition to that, we have about 17,000 or so volunteers through the Medical Reserve Corps. It's a huge effort. These are very dedicated people, passionate about what they do, really committed to protecting the health of residents in the Commonwealth, and doing so with a special penchant for ensuring that the most vulnerable get protected. And I can't speak highly enough about them and the work that they have been doing. So yeah, it's been some amazing stuff.
Dr. Oliver, hi, this is Linda. I want to just echo that. Your team has been fantastic. I know from our health insurance perspective, we've partnered with many of the local health departments to get our membership vaccinated. As a matter of fact, we're doing a partnership with the Roanoke Health Department next Friday. It's been a great partnership, and they are doing a lot of work to really try to get people vaccinated and get the word out.
Yeah. So the health department's been outstanding. And then I would also say the partnerships have been really key. We've been working with a lot of community-based providers, with the pharmacies who have been doing outstanding work, the federally qualified community health centers, insurance plans, healthcare systems. I mean, it's been a, when I was talking about the transformation project, I used the term public health ecosystem, and that's what it is, right? It's a public health is not just VDH, it's that whole network of people working together that's really made a success to our campaign against COVID-19. So we have to build on that and improve it. So we're ready, so we can finish the work of dealing with COVID-19, but so we can be ready for the next pandemic. Hate to say it, but there will be more. So next time we want to be better prepared for it. Why don't you skip ahead to the next slide? Actually, no, next one after that. So it's flu season, and we're out campaigning to get people not only to get their COVID-19 vaccine, but to get their flu vaccine. Last year, the flu season didn't amount to too much, but we can't count on that being the case this year, and need to really get people vaccinated. We're working with the CDC Foundation to hire some more staff to increase our school vaccination coordination efforts, speaking to that VISTA program and other things that we're doing with the schools. Made up this slide before a few days ago, so that next to the last bullet is now inaccurate since CDC has approved that, and we will be doing boosters for 16 and older now. And I believe that might be the last slide.
Do we have more questions for Dr. Oliver, Lisa?
One question I get from a lot of vaccinated folks who are frustrated with the remaining high numbers of unvaccinated, asking if the Department of Health has suggestions as to how to answer that. And one of the big things that comes up is the concept of a mandated vaccine. There are people out there who just don't want to be told that they have to get a vaccine. And the obvious answer to that is sort of, okay, well, if your children have gone through school, they had to have vaccinations for 9 or 10 different things, MMR, polio. What is the difference? It's the same thing. And why do you object to a mandated vaccination for a viral disease that is highly communicable and threatens a larger population? So in sort of digging deeper with that, questions have come up. Are the school vaccination, is that a federally mandated thing, or is that state by state? Where does that come from? I know it's in our code because, thank you, Joe, you sent somebody to find that code section for me that details it. But 2 questions, I guess. One is that, or 3 questions. One, do you think that there is any possibility that COVID-19 as a vaccine might someday be added to the school mandated vaccination list? And where does that mandate come from? Is it governed by individual states or is it federal? And does anybody have a really good answer to how to strengthen that case for people who just say that just don't like the mandate idea?
So The reason, one of the reasons why there's no mandate has to do with the fact that the vaccine is being administered under a emergency utilization.
I'm sorry, what?
It's under EUA, emergency utilization.
Okay, I got you.
That's not true for the childhood vaccines. Those
Yeah.
are fully approved. So that's, I know, one reason why CDC and FDA and others would be hesitant about a general mandate on something like that.
But didn't they remove the emergency? I mean, didn't they get past that emergency authorization thing, or is it still considered?
No, they're still under just EUA.
Okay.
And the mandated vaccines for school-age children is mandated by the legislation by the state.
By the state, okay.
But that being said, the more harder your question really is about how do we convince more
Right.
people to get vaccinated.
Exactly.
You know, the overwhelming majority of the cases that we're seeing are in people who are unvaccinated. And you mentioned the frustration of some who are vaccinated about people who are unvaccinated, and in fact, in that spreading disease, which then endangers not just them, but the entire community, including those of us who are vaccinated. And it's definitely a challenge for us who are vaccinated. There's a term for it in nursing. They call it moral injury, right? And so as a healthcare provider, and the healthcare providers here can probably speak to this, you know, you find yourself in a situation where you're risking your life to protect someone who has a preventable disease that they decided not to prevent.
Right.
Yeah, so I get it. I get the frustration. I get that moral injury. But at this point, it's not something that we can resolve through force of law. It's going to require increased education, discussion, and just little by little whittling away at that resistance. It's my hope, for example, that here in the Commonwealth, going forward, that we have from the new administration some efforts to reach out to his supporters, and you know, he's vaccinated, and talking to them about the importance of being vaccinated, and again, getting back to that earlier issue of having a trusted messenger. Those folks need to get out there and get this message out. You know, the COVID-19 really should not be a partisan issue.
Two quick questions, Dr. Oliver. I didn't see any numbers on Virginians using the monoclonal antibodies. And then second, are any of the mobile clinics in Virginia offering vaccines for flu as well as COVID-19?
On the last question, I don't know whether the specific mobile clinics that we've put out in the last several months they haven't been doing a flu, but going forward, I think they will. The idea is to have both available. I know that our local health departments are doing both, and it's safe to administer both together. So that's going to be our strategy. The monoclonal antibodies, we have a unit of our COVID-19 task force that is really focused on working with hospitals and other providers. And that unit has done a bunch of work around getting the use of monoclonal antibodies increased in the Commonwealth. I don't know if there's anyone on the line who's associated with that unit in the task force who could speak to that. Let's see.
Hi, Dr. Oliver, it's Lillian. I was just getting ready to put something in the chat and accidentally sent it too early, but we do have a web page that has information on monoclonal antibody distributions, and I will put in a link to our latest bi-weekly update so you can take a look at that.
And then Alex, could you then make sure that that gets to everyone on the board?
Absolutely. Thank you for putting that in the chat.
Can I?
Sure.
This is a question on, forgive my ignorance. Okay, so we have decades of experience where mandated vaccines have helped to eradicate diseases, mandated vaccines for school children. The list is very long. It's been mandated for the military, been mandated for schools, for children, and we have eradicated polio, smallpox, Hemophilus. I don't know if people here may not remember. I mean, pneumococcal diseases and Haemophilus diseases in children were killers until now, because that is now mandated. Okay, so here's my question for the legal folks. I thought that the Supreme Court in 1905 approved mandated smallpox vaccine, and that was a legal precedent, and that now we've got all of these other mandated vaccines that are part of a portfolio of required vaccines in children. And again, maybe I'm being very naive here, but we have legal precedent and we have all these decades of experience. What is different now that prevents us from moving forward to incorporate COVID vaccine in the same way?
There's only one lawyer here.
And I think what you'll start seeing is the difference between mandatory vaccination and compulsory vaccination. Mandatory vaccination is when you tie the vaccine to a privilege, like attending school or being able to go to work in a hospital or being able to enter a theater. Compulsory vaccination is the entire population, and that's challenging from a constitutional perspective, and it's also challenging from an enforcement perspective, very challenging from an enforcement perspective. So it's really an issue, in some situations, employers, theaters, you're seeing that some places where you have to have a vaccination card for entry. The Code of Virginia does mandate vaccines for school children. Louisiana did add or is in the process of adding COVID to its mandatory school vaccines. I'm not sure if any other state has tried that yet. But as far as, I don't believe in the Code of Virginia, it's currently, that the health department, for example, has the ability to mandate it for those other than school children. But
Other vaccines are mandated.
For school children.
Yes.
Right. So, I think there have been a lot of discussions, I'm sure you've seen it in the news and in public health groups. The Network for Public Health Law tracks all this if you're interested on their website. I think Supreme Court watchers think that a religious exemption will always be in play. But this court especially is very interested in that. And that, depending on how broadly one interprets that, can be somewhat significant.
Thank you.
To add to that, I really do think it's the emergency use authorization. I think the Code of Virginia, Joe, can correct me if I'm wrong. I think it's the CDC list that they use, maybe with a couple of modifications, but that has to be an authorized use.
Yes, but we are moving to authorized use, fully authorized use.
So Benita is next and then Maribel after that.
So I did do a little research on this. And it seems like my understanding correct me if I'm wrong, but if you were to move to, towards a mandate for COVID-19 vaccine, it would take a law in the state legislature to accomplish that. Is that how, I mean, because my understanding is the CDC makes recommendations about what vaccine should be, for school-age children, what vaccine should be included. But it's up to each state to decide. And actually, Virginia is one of a few states that mandates a HPV vaccine. So wasn't that something that the legislature accomplished, and then we would adopt after that? So it would take someone going to the General Assembly and putting in a bill to require COVID-19 vaccine.
The authority for childhood vaccinations is in Virginia Code Section 32.1-46, and in most cases that code section lists vaccinations. The Board of Health does have some latitude in adding additional ones through the regulatory process. But coming back to the General Assembly, that code section does just address vaccines for school entry.
Madam Chair? Dr. Lori Filano from our Office of Epidemiology is on, and I think she wanted to add some comments here as well.
Hi, Joe. Can you hear me all right?
Yes.
Hi. Good morning, everyone. Sorry for dialing late. I was having some technical problems. So my understanding, I think the conversation's about authority, Robin, and my understanding was that newer language in the code now affords the Board of Health or the commissioner, when they're not in session, technically to review the regulations and make amendments as necessary to be in accordance with CDC immunization schedules. So, but historically, prior to that language being in the code, historically, it's been legislated. And this language is very, very new. So we've never actually been faced with that, I think, prior to this moment. Is that right?
Madam Chair, that's correct. So
Okay.
in 2020, the General Assembly enacted legislation amending this code section. And the legislation did a number of things, but one of the things that it did was it added language to say that make clear that the Board of Health shall amend the childhood immunization regulations as necessary from time to time to maintain conformity with evidence-based, routinely recommended vaccinations for children. And the gold standard that we look to that is the CDC and ACIP. Lori is correct that to date, we have not used this authority. And historically, she's also correct, historically, the regulations for children immunizations have only been amended in direct response to legislation that was passed by the General Assembly directing the board to do so. And we'll talk about the petition for rulemaking that we received, back in September. And of course, that the commissioner decided for a number of reasons to take no action at this time on that particular petition. But the board still does have this new authority in the code. But again, we look to the recommendations that come down from the federal government, from the CDC, to determine what is evidence-based, routinely recommended immunizations for children.
Yeah, and Joe, if I could just make one more comment. And there's a difference between obviously CDC has clearly recommended, for example, COVID-19 vaccine in children age 5 and up. There's different degrees of emergency authorization or full authorization in the current moment. That is, the COVID-19 vaccine, however, is not yet been added officially to the CDC immunization schedule for children and adolescents, I believe that's happened. They will be contemplating that question in February they have a previously scheduled standing meeting where they typically review the immunization schedules. So it's recommended, but not on that official schedule yet, if I understand right. Thanks.
Mary Margaret Snick.
Which
I'm
was
sorry.
that in the 2020 session, the halls of the General Assembly building were inundated with parents and children of the anti-vaxxers. It was a very uncomfortable situation. You walked through and you realized none of these people were vaccinated. So they just wanted to transfer that to the Board of Health, I think.
Mayor Bell is next. Could you speak into your mic?
Sorry, my question has been answered. Thank you.
Oh, thank you. All right. Is there anything else for Dr. Oliver? All righty, then we will move on to Ms. Jansen and the regulatory action update.
Absolutely. And we're just going to take a moment. Mr. Ringer is going to bring up the regulatory memo on the screen in just a moment. And we'll just give it one moment for everybody. And for those of you in the room, this will be behind tab 4.
I am still having trouble hearing, so.
Oh, I'm sorry. Usually I am not so hard to hear. For those in the room, this will be behind tab 4 in your binders. And so what you'll see, Madam Chair, is that there are 22 pending actions currently under development, and you can see where they fall in terms of which stage they're going through, be it NOIRA, proposed, final, fast track, or emergency amendments. There was also a spreadsheet that was sent out detailing the steps and progress of these items sent out to the board. So that spreadsheet should be available to you. Scroll down a little bit. So we've touched on this a little bit with the questions for the pardon me, for the commissioner's report. But I'm going to turn it over to Mr. Hilbert to briefly discuss a regulatory action taken by the commissioner on behalf of the board since the September 2nd meeting.
There you go. So this is just a continuation of the discussion we were just having. So the Virginia Administrative Process Act allows any person to petition an agency to either amend an existing regulation or promulgate an entirely new regulation. We don't get many of these. I think we've gotten about 13 or 14 of them since 2004. But the Administrative Process Act does lay out what agencies need to do if they do receive one. We post it to the Virginia Regulatory Town Hall, and there's a 21-day public comment period. And then the agency has 90 days from the close of the public comment period to decide what they're going to do with that petition. They're either going to grant the petition and then initiate a regulatory action accordingly, or they can take no action. And if they take no action, we need to make public our rationale and justification for that on the town hall website. So we received a petition back in late August, and the petition contained 2 requests. One was that vaccines should be mandated for all school employees, and also with only medical exemptions allowed, and 2, to mandate vaccines for all students for whom the vaccine has been approved. I will say that the petition was not specific as to COVID-19 vaccine. It was written more generally. So we posted this petition on the town hall website as we're required to do. And we received a tremendous amount of comments during that 21 days. We received more than 15,000 comments, which we then had to review and summarize, which we did. A summary of those comments can be found in this document that's behind tab 4. I will point out that the vast majority of the comments that we received, more than 93%, expressed some form of opposition to the idea of mandating vaccines. After careful consideration and based on recommendations from staff in our Office of Epidemiology, the commissioner decided to take no action with respect to this particular petition. The rationale and justification for the commissioner's decision is explained further on in the memo. I will just kind of highlight some of that for you. And again, some of this is a bit repetitive of the discussion we just had, but just for context. So VDH does not currently have any vaccine mandates for school employees. There are currently school required vaccines for 15 different disease states right now, and those are in our regulations. We mentioned earlier the Advisory Committee on Immunization Practices, ACIP, which is part of the CDC. They recommend immunization schedules, and then the CDC, the American Academy of Pediatrics, and the American Academy of Family Physicians approve and/or adopt those schedules. As I mentioned, our regulations are based on maintaining conformity with evidence-based, routinely recommended vaccinations for children. We reviewed the Commonwealth's current immunization requirements for school attendance and compared them to the recommendations that are set forth by ACIP, and a description of the differences identified is shown in Table 3, which is in this memo. So I'd point out, and staff in our Office of Epidemiology and our immunization program would tell you, that multiple factors influence decisions to require immunization for school attendance. And those factors include things such as the ACIP recommendations, fiscal considerations, the feasibility of implementing the requirements, and other types of administrative burdens that may be associated with specific immunization requirements. With regard to the request in the petition to mandate vaccines for school employees, VDH does not have clear statutory authority to promulgate regulations for that population. So we can't promulgate we can't exceed our statutory authority in promulgating regulations. So that's the school employees. In terms of the children, the students themselves. So at this time, all of the vaccines that are required by the regulations are in alignment with recommendations from ACIP, the CDC, the Academy of Pediatrics, and the Academy of Family Practitioners, with the exception of influenza and COVID-19. VDH has determined, looking at it from our immunization program, we've determined that requiring influenza vaccine annually for all children for daycare and/or school attendance would have significant costs to VDH, the Department of Medical Assistance Services, which administers our Medicaid program, and school systems and daycares themselves. It would also be complex to implement a requirement for school attendance because the new annual vaccine typically does not become available until late August or September, which coincides with the start of the school year. Now, with respect to COVID-19 vaccine, that's been added to the CDC Immunization Schedule webpage, but it hasn't yet been added to Table 1, which is the recommended child and adolescent immunization schedule for ages 18 or younger for the current year. So that's significant in our estimation. Just to summarize the rationale for the commissioner's decision, again, in light of the lack of clear statutory authority to implement vaccine mandates for school employees, decided to take no action on this petition. And in addition, given the continued administrative, logistical, and financial burdens related to influenza, and also given that the COVID-19 vaccine has not yet been added to the Adolescent Immunization Schedule for ages 18 years and younger. For that reason, the commissioner decided to take no action as it relates to vaccine mandates for students based on the request in this particular petition.
Any questions? Jim?
I understand the rationale as Joe has explained it. Does it, there's an implication that maybe the issue would be reconsidered next year, given action that might take place at the CDC level in particular within the next 9 months.
Is that a question for Norm?
I think that's a reasonable conclusion that we could readdress this if the CDC were to put this on their schedule of childhood immunizations.
All right. Well, if do we need to, we don't need to take any additional action, do we, Alan?
No, I just need to finish going over the rest of the memo,
Okay.
ma'am. All right. So what you'll see on the board is, on the screen, is our list of current periodic reviews. So there are currently 16 periodic reviews. So a little less than, I believe, the 19 that we had going on last year, or in September. So if we scroll down a bit, the last thing I just want to highlight on this is this last section is all of the executive branch review activity that's been completed since our September meeting. So here you can see the different regulatory actions that have been completed in their review by the Office of the Attorney General, the Department of Budget and Planning, the Secretary of Health and Human Resources, and the Governor. So we have additional actions pending, and you can find more information in the spreadsheet.
Right. Are there any questions for Ms. Jansen? All right, seeing none, we are going to take a brief break. We are having a lunch presentation today, but lunch is not here yet, correct?
That's correct, Madam Chair. It's scheduled to arrive at about 11:30, which is about when we were anticipating we would get to it. But we are running a little bit ahead of schedule, something I will not complain about. And so if we wanted to have a slightly more extended break, that might be helpful.
Unless I miss my guess, folks would very much like to stay on schedule today. So I think what we will do is we will take our brief break. If we can, we will begin our presentation. And in a good model of servant leadership, when the lunches come, I will bring them to your tables. Fabulous. All right, break, 10, 15 minutes, come right back. Mr. Helper.
Are we, okay.
What?
Thank you, Madam Chair, members of the board. So um, we are still waiting to hear from the administration which of our legislative proposals that we submitted back in August, which of those might be approved to be introduced as bills in the 2022 session. I was kind of expecting that we would have known by now, but we still have not heard. We did submit about 9 different proposals to the administration for their consideration, and that was following a lengthy internal process where we work with our staff and we work with the commissioner's leadership team to develop ideas and vet them internally and make some decisions about what we want to recommend to the administration for legislation. So I said we submitted 9 things. Based on my reading of the tea leaves, I believe that there are 2 of our proposals that might still be under some consideration by the governor's office. Both of these items would have a fiscal impact that we addressed by submitting budget amendment requests to accompany the legislation. So obviously the governor Northam will be presenting his budget bill to the money committees on the 16th. So I suspect that one of the reasons we might not have heard definitively yet is they're still finalizing what's going to be in the budget and how much money and for what specific purpose. One of the items that we had submitted was that might still be under consideration was dealing with on-site sewage systems. And we had a proposal that would authorize VDH to provide oversight of the Chesapeake Bay septic pump out and inspection programs in all 12 localities in the Three Rivers and Eastern Shore health districts. So these localities are under the requirements of the Chesapeake Bay Act, which include requirements for annual pump outs of on-site sewage systems. Right now, those pump out responsibilities are supposed to be enforced by the local governments. We were asked by the General Assembly a couple of years ago to do a review of many issues dealing with septic systems in that area, including the pump out requirements and what they are and how they're enforced. We convened a large group of stakeholders to do that study. And one of the recommendations of that study was this particular legislation, that oversight for those septic pump out requirements be moved over, be given to the health department. So that's what this proposal would do. There would be a significant fiscal impact on our staff, particularly in those 2 health districts. And that's, so we put together a budget amendment request, which has been submitted. So again, we're still waiting to hear. This one may or may not still be under consideration, not entirely certain. And another one that we submitted that may still be under consideration and would have a significant fiscal impact is dealing with infection prevention in nursing homes. And this is a proposal that was developed jointly by our Office of Epidemiology and our Office of Licensure and Certification. And it would direct the Board of Health to amend the nursing home licensure regulations to require that nursing homes have mandated minimum hours of infection control and prevention training on an annual basis, and that they would also have to have a full-time infection preventionist if they have more than 100, if their facility has more than 100 beds, or if they provide on-site ventilator or hemodialysis services. So this would have a, as you all probably know, nursing homes are receive the vast majority of their funding from the Medicaid program. So this proposal, if it happened, would have a significant fiscal impact on the Medicaid program. We know that. So we worked with the Department of Medical Assistance Services to develop a budget amendment request for additional, that would provide additional Medicaid reimbursement to, to cover this additional cost that the facilities would have. So again, those are the two that I think, based on questions and feedback that we've gotten from the administration, that may still be under consideration. We don't know yet if they're going to be approved. But Madam Chair, that's the legislative update. And I guess the only other thing I would say is, just in terms of getting ready for legislation, we just hired recently, we're bringing on a new legislative and regulatory coordinator by the name of Michael Capps, who has been with our agency for a few years, in different policy analyst roles. So he's going to be a big help to myself and Alex as we deal with what I fully expect to be another onslaught of legislation that we'll have to monitor, track, evaluate, and make recommendations concerning.
Any questions for Mr. Halpert? Do we still not have our presenter?
We do not, Madam Chair. I'm just going to go see if she is in the lobby. Oh, Mr. Ringer is going to go check for me.
Can you remind me which of our items do not have speakers?
Is that public speakers, Madam Chair?
Ah, yes. Yeah, you said there were a couple of items on here that we did not have speakers for, and maybe we can go ahead and take those. You can do what? We could do member reports. How about that? That's easy. Is that okay?
I think,
Okay.
is that Dr. Aplaska? Oh, perfect. She has arrived. Our lunch speaker has arrived, Madam Chair.
Are you ready, or do you need a moment? We're ready. Come on. Welcome. He's going to be speaking behind us, yes. I guess we will turn. The whole day is a little weird. And yeah, maybe 2 now. Yeah. That's right. Wait.
Yep.
Yeah, no problem.
So we're awkwardly not looking at you.
That's okay.
But we will try and turn and give you some attention. So
Please don't feel the need to turn around. Enjoy your lunch. I know you have a long day. And the slides are ahead of us. You don't need to see my face.
all righty.
That's okay. That's okay. Well, I will just go ahead and get started. I know I don't have too much time and there's lots of slides. We'll probably advance through them quickly, but I just thought it would be good to put them in there. And the topic really around operating this behavioral health system in the times of COVID
the challenges we had beforehand and the new kind of opportunities we see moving forward, and what we've learned from working so closely with public health agencies over the past 18 months or so. So you can go ahead and advance the slide. These are the kind of the 4 high points, really the behavioral health impact of COVID-19, what has happened to our service delivery during the pandemic, the state of the state hospitals, which are always in the media, and then the behavioral health system transformation and what that looks like moving forward. Next slide. Next slide. You can click through and show the 2 graphics on here. But basically, you know, when we were anticipating what would happen during COVID-19, there were a lot of studies out of HHS around what we're going to expect. So this, you know, we saw this in the beginning of the pandemic where people were banging on pots and ringing doors to really support our frontline workers. And the pandemic went on, and there was this kind of feeling of hopelessness and helplessness that came on to our frontline workers that we really needed to respond to. And then that sense of isolation and grief and loneliness as a result of the pandemic. And then we had, you know, things that came up that weren't really reported as much anymore because people weren't accessing the usual routes, like domestic violence and child maltreatment, the rates of substance use, and those things that we have in our monitoring were just not there anymore. And so this graph really just represents sort of that cascade of mixed emotions and feelings that people were experiencing throughout the pandemic and what they continue to now that it's kind of ongoing. So next slide. And then they showed 3 different potential timelines of the impact of COVID-19 and these wave scenarios. And number 2 is really where most people thought that we would land, where we would kind of have this lull and then kind of come back up again and reach the level of stability and sense of where we need to kind of sustain everyone's emotions there. So next slide. You can click through this graphic on here too. And this is that trauma cascade, so that depression and the substance abuse and that fatigue, the exhaustion and burnout is really what happens. So of that projection there. You can click through this one since we went through that graphic. And we saw that in Virginia. So this is data from the OCME's office about the rates of suicide, homicide, and overdose deaths in the context of COVID-19. We saw a huge uptick in drug overdose deaths. And I put this in the context of the behavioral health services because all of these things obviously are directly impacted. So either a result of a mental health or substance use disorder, or will be the trigger for the development of mental health and substance use disorders. Next slide. So what we had during the pandemic was really challenging. So we relied heavily a lot on our public mental health system, the community services boards. We have a number of code mandated services that are operated by the CSBs who really served as the foundation and backbone to our mental health system during the pandemic. We had to make a lot of changes operationally by prioritizing essential services such as pre-screening, so the ECO and TDO, the involuntary commitment, discharge planning from institutions and other hospital settings, and then diversion from inpatient hospitalization, which were being just hit with COVID-19 cases. Those congregate settings were just devastating in those settings, and the more that we could divert, even more so than we already needed to, became suddenly even more important than we ever realized. Some of the benefits related to mental health is that there was a lot of quick transition to telehealth. So most of these code-mandated services are written to be face-to-face. That's what's required. But with the allowance of telehealth and the face-to-face visits, one of the services that really appeals to that is mental health services. We don't do a lot of hands-on intervention and diagnostics. And so a lot of those services were related there. But of course, the cost, the sustainability of operating in this way during the pandemic was very challenging. So PPEs, testing, there was a lot of staff that were furloughed because some services really couldn't be provided via telehealth. And so about 25% of the CSBs engaged in some level of staff layoffs during the pandemic. So we have a really stretched workforce that is now being stretched further, and not directly because of COVID-19. They weren't directly infected with COVID-19 that prevented them from working, but really the services where they provide the expertise weren't available to be offered, and there was no way to sustain that by the CSBs. So that was a real challenge on the workforce. So next slide. And then on the private provider side, we kept track at DBHDS. They're required, all private providers licensed by DBHDS are required to report to us when there's a change or modification to the way they delivered services, either reducing services in some fashion, changing the way it's delivered, changing the patient population or client population. And so this is what had been reported to us over that past year. So this was data from last year, sort of at the height of the pandemic, where about over 600 providers had to really change operations, where they really, I mean, this wasn't an infrastructure that already existed where we could pivot very quickly. And so it really showed the flexibility and the resilience of our providers to be able to meet ongoing high needs during the pandemic. So next slide. And one of the ways that happened was through our partnership with DMAS. So CMS allowed a lot of flexibilities to occur, and there are still some that are starting to sunset now. That has allowed telehealth allowances, so expanding services where telehealth wasn't usually allowed, allowing originating sites where telehealth usually had to be a facility place, and then the provider had to be in a certain location, but now services were provided directly to a person's home as an originating site, which was previously not allowed. And then also audio only services for things like case management and kind of all the touch base to really ensure that those infection prevention and limiting transmission in the community was being upheld in the light of PPE shortage and ongoing uncertainties related to COVID-19. So next slide. So in summary, and you can click through this, what we saw over the pandemic based on our Medicaid data was that while other services, medical services, decreased, the BH service utilization actually remained relatively stable. So that was a big surprise for us. We thought that it would go down, similar to the decrease in PCP visits, OBGYN visits, and routine care visits. But that telehealth flexibility really allowed people to connect to providers in a different way. So it changed from this group model of receiving services to this now individual service. And so we saw that increase there. And so people were getting care. We're not seeing yet the surge that we're anticipating. So that cascade in that first slide where we're anticipating the surge of new needs for the behavioral health setting, we haven't seen that yet. So we're sort of theorizing, we're still in this honeymoon lull phase where people are starting to get back to normal. But as those stressors start to come back again, as people re-enter the workforce, schools, and things like that, we will start to see that surge again. And, we were actually really happy to see that the providers were able to adapt pretty easily to this combination of telehealth and face-to-face delivery services to provide services. But what we're hearing now from the providers is that while that utilization remains stable, the financial reimbursement for those operational costs were just not enough to cover. So we are anticipating sort of a hole that we've created by being able to continue the services, but really haven't accounted for all of the other infrastructure in providing services in this changed way. And so you might think that some of that might be offset, but less need for traveling, mileage, gas, hotel stays, and overnight stays, because we have our providers that go out into the rural communities and cover large areas of the Commonwealth. But we're still trying to better understand kind of where those needs are and what the long-term need might be to sustain this kind of model. So, right. And then the next slide. And I'm kind of going fast through sort of the Virginia update so I can kind of get to the path forward, which we want to collaborate with, but is the mental health hospital. So there's an article back in 2020 in April that called Coronavirus in the Psychiatric Hospital, the Worst of All Worlds. And they interviewed Dr. Tressman, who is the chair of psychiatry at Virginia Tech. And he really just made some very poignant remarks that we saw throughout the past year and we continue to see, which is that we design these facilities in these congregate settings for psychiatry to keep people together. We essentially, if someone is admitted to a psychiatric hospital, the door to their room is closed because we want them to have social interactions with other people, and it's actually the therapy. It's not a choice in those settings, that this is the therapy that you receive there. But all of that had to change. We really were at a loss about how to get people better in a short period of time in an acute psychiatric stay while preventing the transmission of COVID-19. And this was it was hard. It was very challenging. So go to the next slide. This our state hospitals only right now take individuals who are under a temporary detention order, so under a civil commitment. And over many years, we have seen this incremental rise in admissions to the state hospitals. We talk about a lot in the media and every presentation to the legislature. And when the world shut down related to the pandemic, we saw almost a 50% decrease in admissions. So we were anticipating that these hospitals would remain full because there are now no other mental health services in the community, things that people normally access. But for the first time in a long time, our state hospitals had a breath, took a chance to breathe, to take care of the individuals that were directly in their care. And it wasn't this barrage of admissions that were coming through the door. But as soon as the doors opened again in June and July, those numbers went back skyrocketing and even higher than what we anticipated. And so by June, there was over a 15% increase from previous year, from year to year. So kind of back on the same trajectory as we were pre-pandemic, but now with the aftermath of coronavirus and the isolation and the change in people's lives that is starting to kind of come to a head. So if you come to the next slide. The doors opened and so did jobs for some of our frontline workers in these areas. And by March, by April, May, we saw a mass exodus of the staff at the Department of Behavioral Health. Those facilities who were battling COVID all year, who have sustained the 100+% census prior to the pandemic, just didn't want to do it anymore. They just could not do it anymore. We had about 1,500 vacancies at the facilities, while the rates of admissions continued to climb throughout the summer until now. And so this represents the current capacity of what we've had. And so the commissioner had decreased the number of available beds because of this massive staff exodus. And then, so that brought down the total census and then the total utilization continued to remain at 100 or higher. Now, one of the hospitals that has never recovered and still hasn't recovered is the Children's Hospital, the Commonwealth Center for Children and Adolescents, who had an outbreak back in August of 2020 that affected about 30 staff, and they experienced their exodus immediately after that. The nurses, direct care staff, physicians, NPs quit right after that outbreak and then never came back. So it's a hospital that has 48 beds in it. And despite efforts at recruitment, maybe we got to open as high as 24 beds for about a month over the past 18 months. But we are now at 13 beds because of the staffing and just the inability to recruit child specialists that work in that location. So whereas the other facilities who are also hit with outbreaks, those we were able to kind of hire other staff and use contract staffing to bring those numbers up, but the children's has really been hit very hard. The next slide. And this is just a snapshot of where we are today with our COVID-19 cases at the state hospitals. So over the past 18 months or so, we've had over 1,900 cases of COVID across all of our 12 facilities. We've had 28 deaths from COVID-19, particularly in the geriatric hospital, which has been hit hard, which I'm sure is no surprise to most of you. And we are currently seeing a surge of cases since the beginning of Thanksgiving. So prior to Thanksgiving, we had about 8 cases of COVID across all 12 facilities, and now we have over 40. So, I had kind of talked about this as part of the long-term care task force. And we got interviewed a lot at DBHDS about, how are we going to keep COVID-19 out of the facilities, and people are worried about keeping their loved ones and friends safe in there. And, the answer that I've been giving is that the best way to keep people in these settings safe from COVID-19 is to keep yourself safe in the community. Because what we see is that the trend in the community immediately is reflected in those congregate care settings. So if we don't want those people who don't have a choice about where they are at the moment because they're in an institution or a congregate care setting, and that's the safest place for them, we need to help drive those numbers down across the board, across the state. Next slide. So this is really where I want to spend kind of the biggest time. And so I know that you've seen this headline a lot, but the biggest problem that our state has is this bed shortage and the lack of bed capacity. So next slide. And really, there's only so much you can blame on lack of bed capacity, because those beds only represent a very small portion of an entire functioning behavioral health system. And the more we rely on it to solve the issues related to things like substance use disorder, homelessness, violence in the community, the more we're going to need those beds. So next slide. So our vision for the Commonwealth, and you can kind of click through all this part, is to develop an evidence-based, trauma-informed, cost-effective continuum of care. We want to follow the lead that the health department does for all communities, which is to keep those Virginians well and thriving in their communities. We want to improve their behavioral health services and their outcomes. We know there's limited resources, so we want to optimize the dollars that we have and invest in prevention and early intervention of mental health problems. I mean, these are fundamental public health, Department of Health tenets that we don't talk enough about in mental health. And then also we want to provide care where people naturally seek support. So kids are in school, and that's where those behavioral and emotional needs first manifest. They go to their primary care office, and that's where they might feel the most comfortable. And so we want to be able to meet them there as well. The next slide. So part of this started many years ago in 2017 with Step Virginia, which is a program that's being implemented by the Department of Behavioral Health. And it really looked at that time to make sure that each CSB had a core set of 9 services. So right now, if you go into a CSB, RBHA will have an FQHC, but Goochland won't. And RBHA has kid services, but Hanover might not. And what we wanted to do is create more of an even playing field so that if you went into a CSB, you could expect some foundational services be available through that CSB. And that's the purpose of Step Virginia, to increase access, accountability, and quality of those services in the public health sector. But what it doesn't do is change what's already available in terms of services in the community. So the services that people access through the CSB are usually paid for by Medicaid. So those are those private providers. So you can come to the CSB, be seen on the same day, get a full psychiatric or mental health evaluation, and that person might say that you need to start outpatient therapy or intensive in-home therapy, and this is what Medicaid pays for. And those services, if you go to the next slide, haven't been changed in over 20 years. And so in 2018, we started to work with the Department of Medical Assistance Services, or Medicaid, to think about how to update that service array through Medicaid. And we wanted high quality, evidence-based, trauma-informed, cost-effective care, but we wanted it to look more like a continuum. So Step Virginia, if you think of just columns that are holding up a building, we needed things to fill up those columns, kind of the overall structure of that system. So next slide. And this is from the Institute of Medicine, and we use this graphic to really demonstrate to the General Assembly and the administration that we need to include elements of promotion and prevention, not just response to crisis, treatment, and recovery, that we can keep people well with mental health interventions that are grounded in evidence, and we need them here in the Commonwealth, and we need them to be paid for. We need that investment to be really part of what we talk about when we talk about mental health. So the opposite side of the need for beds is keeping people well. The next slide. So this was the current Medicaid funded behavioral health system, and that big purple chunk in the middle represents what was previously called community mental health and rehabilitation services. That Medicaid spent over $1 billion a year on those services, and in order to access them, you either had to be a threat to yourself, displaced recently, homeless, incarcerated, be at risk for foster care placement, at risk for juvenile justice. And so you already had to get to this far, far part along the spectrum to access these services. And so not only that, those practices there were really poorly reimbursed because they weren't really grounded in any evidence that has kind of come up in the past 20 years. So if you go to the next slide, we broke down that big chunk there so that you don't go from an acute inpatient stay and acute need into one that is more stepwise, so kind of more reflective of the need for prevention throughout each step. And this is the long-term vision for the development of this robust continuum. And so we presented this to the General Assembly and then started to put things in motion. So how do we get people out of these institutions? The next slide. So we built on the foundation of Step Virginia to develop Project Bravo, which was the embarking of the build out and the implementation of that continuum. Next slide. So as of July 1st of this year. First 3 services went live, which is Assertive Community Treatment. This is an adult-based service that is essentially hospital without walls. It's for individuals with serious mental illness, partial hospitalization, intensive outpatient treatment. And then as of December 1st, the implementation of 6 more services, including a comprehensive crisis continuum. And I highlight that crisis area because it's almost like a continuum of itself. Some people will need a call, some people will need direct intervention, and some people will need to be a safe location. So if you go to the next slide, and we can skip this just for time, but it really takes coordination at every level. So this includes the integration, the federal integration of 988. So if you call 988, it connects you to all your crisis centers across the state. Those will be done regionally, and then the local law enforcement will be implementing the Marcus David Peters Act. Next slide. And the Marcus David Peters Act was passed during special session in 2020, and it was named in honor of a young Black biology teacher who was shot by police in the midst of a mental health crisis. And the purpose of really transforming and integrating these Marcus Alert is that we want a behavioral response to a behavioral health crisis, not a police response. So much of prior to all this work around crisis transformation is that if you had a crisis, police would be the first responders, and they know how to respond in one way. We do a lot of mental health training, but at the end of the day, part of the process is a legal one, not a mental health one. And so this, the first of these started on December 1st, and we're happy to say that we do have some reports of regions diverting from police response into these regional crisis call centers and providing mobile crisis instead of a police going out to meet somebody for a mental health crisis. And so this is just growing, and we're looking forward to kind of the fruits of that as well. Next slide. So what we really envision, and this is based off a national model called the Crisis Now model, is that these system alignments would go towards a common goal so that you have a person in crisis, the people that are filling up the state hospital beds right now and inpatient beds across the state. And instead of going directly to an emergency room, they would call the crisis line here in Virginia, talk to a mental health provider, and about 80% of those, based on national data, would be resolved at that point. Some might need a dispatch of a mobile crisis team. And again, those would avoid emergency department visits. Some might be discharged from that community setting, and then some will just continue to receive wraparound care. And what we really intend to see by building out community-based services and de-emphasizing the need for beds is a decrease in the use of jail, ED, and inpatient settings for mental health. Next slide. So, the pandemic has really shown us a lot of things related to mental health and really changed the trajectory of where we thought we were going without the pandemic behind us. And so it has shown us all the gaps in Virginia's behavioral health care system. So we know that there's deficiencies in every service level, that our workforce is very fragile in terms of number and scope, a lot of under-resourced systems, but it's also showed us a lot of resilience of the behavioral health system. They've operated in crisis for a long time, and they know how to continue to do so. They've been very flexible and innovative, and we also know that they're very socially minded and diligent. They really care about each other in the community to keep each other well and want to do the best thing for the people around them. The other part that it has done is expose all the opportunities moving forward for Virginia's behavioral health care system. So we do view this opportunity as a time for major change and to highlight and advocate those with high needs. And also the need now to prevent and mitigate long-term negative mental health effects through the widespread use of public health efforts at every level. And so we are in the thick of this now, and we're hoping to see the fruits of our labor. And the next 12 months or so as we continue to build out all these services. That takes me to the end of our talk. I know I sped through a lot of it and there's a lot of information in there, but I'm happy to answer any questions or respond to email if need be.
Well, thank you very much. Are there questions for Dr. Aplaska?
First of all, thank you. That was very informative. And the workforce issue is really, it's a crisis in all the hospitals that I'm working in. So I really understand that. I guess I'm a numbers person. If you think of this care as a pyramid, how many people what's your numbers of Virginians that you need to take care of or that you're trying to, I was just trying to get a handle. Is it 2% of the population, 20, just to get a sense of the scope and then capacity or accessibility to, if you say it's 10 people, but you only have access for 2, just to get a handle on those two concepts.
Yeah, the data that we have been using to kind of anticipate how many people we might reach that would receive services is Medicaid data. So Medicaid is the largest payer of behavioral health services here in Virginia. And based on Medicaid data from a couple of years ago, when we were putting this together, about 30% of Medicaid members will need behavioral health services. And so that was pre-expansion, and then that includes the number post-expansion, Medicaid expansion.
So that's a huge number of people.
It's a huge number.
And then what's your capacity? I mean, let's say you don't have capacity to take care of them, obviously. So all of these great plans, I mean, this is what I sit on lots of different health boards, and it's always frustrating. So many good plans, but it's like trying to force a fire hose through a pinhole. You can't get the people into these fabulous programs because there's way more need than there is ability.
Yeah, Virginia is a little bit more, is even, not to kind of put more, throw another wet blanket onto this, but when we look at the Mental Health of America report, Virginia is ranked 41st, sometimes 43rd in the nation for mental health workforce. And when we engaged with the Farley Center in developing the Continuum, one of the things that they also looked at was Virginia's workforce. And the services don't match up with what people are trained here in Virginia to do. We have a lot of great psychology programs, social work programs, counseling, medical schools, nursing schools. But when you go out into the field and you're being asked to practice an outdated service, that's not what they went to school for that whole time. So we have a mismatch. We have sort of the foundational parts where we're growing this workforce, and then we don't have anywhere for them to go. We either don't reimburse them enough, or the services that we provide are just not what they learned. Nobody's learned how to do mental health skill building if you went to graduate school for social work as a service. And so what we're trying to do is decrease and match the skill level that people have as they're coming out of school with the type of services that they want to practice. And they've seen that in other states where they have more evidence-based programs infused to the services that they provide, and therefore bring in a lot more licensed mental health workers. So it'll be a struggle, but that is really one of the first kind of steps there for us.
Seems like a lot of the community colleges are often great places to build these sort of programs where you need, ground level workers for a very specific niche. They're very open to building programs that are helpful in the community and have immediate impact. I don't know if you've looked at partnering through the community colleges.
Yeah, I agree with you. I don't think we've done that enough.
Other questions?
Sure.
I'm sorry, Jim.
I've actually got two totally unrelated questions. The first is, which of the programs that you've described for us are specifically targeted at the vulnerable people who have been providing services? I mean, we as Holly mentioned, we're seeing stresses in the provider workforce. And one of the, I sit on the board of an affordable assisted living facility, which has certainly, that we've done very well compared to many, but we've seen evidence of enormous stresses on the workforce. Is there something in the way the department is set up to address the people who are delivering services at every level? I mean, from hospitals on down to assisted living facilities.
I didn't present it here, but we do have and had received grants from SAMHSA to stand up a couple supports for frontline workers. So one was Frontline Wellness Virginia. Another one was Virginia COPES. And then we still have ongoing funds for frontline mental health workers to also receive support. There's some other national ones that I actually participate in, which is called the Physician Support Line. That was specifically for physicians. It's staffed by board certified psychiatrists and respond to calls from physicians across the country who have been working throughout the pandemic. But I didn't put that here, but we do have a couple of resources that are ongoing right now that are grant supported.
I might suggest that your department make a specific effort to reach out to the operators of institutions, managers and otherwise, with information about how their workforce, particularly the relatively low paid workforce, can access your services. Yeah. Second, unrelated question. At our last meeting, we had a representative from the Virginia Department of Housing talk about the links between housing and public health. Couldn't be more valid. In trying to obtain funding to develop affordable housing, one has to go through a couple of state agencies and local governments in order to access the funds. And one of the requirements is always to provide a certain number of units in a housing project that's proposed that would that would be set aside for permanent supportive housing, people with special needs. Is that a connection that you make with Virginia Housing, the Department of Housing? I'd like to hear how that works, because my observation is that case management is sorely lacking. And one of the reasons it's sorely lacking is money.
We have our permanent supportive housing director who works very closely and is part of the community behavioral health team at DDHDS and works directly with individuals who have mental health needs or diagnoses that we want to sustain in the community. And that's actually probably one of our strongest programs, where we demonstrate evidence in terms of the interventions to decrease the hospital census, because housing is health, right? So, I mean, if we want to be able to help a person with serious mental illness be sustained in the community and reintegrate into programs and day support and outpatient work, they need a place to live. They need a residence. And so we often use the data from permanent supportive housing to sort of demonstrate how well that program works. And we work closely with Virginia Housing Authority to stand up those programs as well.
Again, I have a suggestion. It would be helpful if, in issuing the notice of funding availability, or the RFPs for the availability of affordable housing finance, if somehow the Commonwealth could get its agencies on the same page, so that funding for special needs units within affordable housing projects could be targeted for the case management and support services that those individuals need. It isn't now. It's just, and it needs not to be that way.
I'd like to come back.
Yeah, I just wanted to speak to this a little bit, Jim. The person that Dr. Plaska was talking about, who from DBHGS works on that work, is part of an interagency team. There's an interagency leadership team that includes Housing Community Development, the Housing and Development Authority, BDH, DBHDS, DMAS, and some others, and has been working on this issue of permanent supportive housing for a number of years. That grouping, we identified about a population of about 5,000 or so, and has placed about 1,500 of them so far into permanent supportive housing. And by definition, what we're talking about is, with the supportive term in there, is having the case management and other things that they need so that they not only have the dwelling, but have the wraparound services that they need. And there has been some money that's been appropriated for that in the last session of the GA. So that's going to be stepped up. The last, I don't know if this is quarterly or annual, but the report on this work just came out and will be published soon. So I'll talk with Alex and we'll see about getting that to the board. So you can see there's been some really good work that's been done on this in the last year or so.
All right, thank you very much.
Thank you. Thanks for your time and inviting me.
I want to say that we enjoyed your presentation, but it is a little bit bleak for enjoyment, but we appreciate the input.
Well, it's good to see people in person.
Yes, it is. Thank you very much. All right, we have now come to the point in our meeting for public comment. As a reminder, those who are signed up will be unmuted by the host when it's your turn to speak. All speakers are reminded that this is an opportunity for you to address the board on any topic of your choosing. However, it is not a question and answer period, and there will not be dialogue back and forth between speakers and the board. Ms. Jansen, we have 5 people signed up.
Yes, Madam Chair. And I just wanted to add, I have a running list, and Dr. Aplaska's presentation, she also had some handouts. So I'll make sure that that's distributed to the board as well.
Thank you
after
very
the
much.
meeting.
I would much appreciate that. So the board's participation policy calls for a public comment period of a maximum of 20 minutes with 2 minutes per speaker. And so we will start, and the timer, do we have a timer on the screen, Alex, or?
Mr. Ringer is bringing it up.
And are we ready for our first speaker?
Yes, Madam Chair. I will be calling 2 names at a time. The first is the person who will speak next, and the second is the person who will be on deck to speak next. So there will be the timer on the screen, and so when that timer goes off, it'll flash, and we will let you know that your time has expired, and move to the next person. I am looking through the list. Our first person who is signed up is Nancy DeFranco, and then on deck will be Mitchell Opalski. I'm not 100% sure. I don't see Ms. DeFranco's name in the list of attendees. She may be this person, so I'm going to unmute and ask them if this is the correct person. This is call-in user 6 with a 540 number. Is this Ms. DeFranco? Hearing nothing, we will move to Mitchell Opalski, who will be followed by Jennifer Grouper, who is in the room with us. Mr. Opalski, you are unmuted, so you can begin your time and we will start the timer.
I'll just remind all the speakers to please speak up so to make sure that we can hear you.
Mr. Opalski, are you there? You should be unmuted. Oh, he's unable to speak at this time. You can send in written comment. The information about that is on the meeting notice, and we'll come back to you at the end of the meeting. Ms. Gruber, if you want to step up to the podium, and then on deck will be Ann Tatus.
Thanks for having me. My name is Jennifer Gruber. I'm in Rico. I really appreciated listening to everything and hearing how things work. I just attended a really moving meeting last night. There was a meeting of the Coalition Against Violence of all the people in Richmond that have family members that were killed through violence last night. It's usually at City Hall, but because of COVID, it was on Zoom. There were about 60 people with all the people, multiple family members. People were talking about their children, their sons and daughters. A couple of people, it was their only child that was taken from them. A lot of people lost people this year. And I just was really helped with listening to the mental health person speaking. I think I'm going to be sharing some of the resources that she shared, or I might email her, and because a lot of the families were saying some of them had lost a child 20 years ago, and they said every day it's 1 second at a time. You know, you have different chapters in your life. You never really recover. You just one chapter at a time. But they said they would need more resources. They kept saying, who can we go to? I'm a grandmother. I raised my son. I was a single mom. I lost my son. Now I'm raising his daughter. And she's like, one day at a time. So I really feel for these people. I haven't lost anyone, but I was a volunteer. And they really were heroes, how they were dealing with it. So I'm glad to hear that there will God willing be more resources for people like that. There's a lot of people we maybe don't know about that go about their lives and have a lot of trauma and difficulties. So it's good to know that this is possible. And I like the idea of like a hotline or a phone line that people could call. Because if you're a grandmom with your grandkids, you're not going to be able to go somewhere and talk about things about losing someone because you don't want your kids to get upset. So it's good to know maybe they could call, or even a texting. Maybe they could text and say, I'm going through this, and talk to a crisis person through text. I wanted to talk about the COVID situation. I'm Jewish. I want to talk about how I'm hoping that with all these different differentiations of opinion that we can still all come together, and the people aren't going to be classified in different ways based on their beliefs. If they believe in getting the shot, if they don't believe. I think that, health should be encouraged, vitamins, vitamin D, zinc, but that we can try to do whatever we can, whatever different modalities that we have to treat people. If they have religious reasons, I have friends that are Black and they're afraid of sometimes of vaccines because of the testing or the treatment of people in history where they were used as test subjects. So we have to take people where they are and just treat them where they are and try to help them as best as we can and love everyone as who they are.
Ms.
So
Gruber.
thank you. Sorry.
Thank you. Our next speaker will be Ann Tatus, and on deck will be Doris Nick. Ms. Tatus, you are unmuted.
Okay, how are you guys doing? First, I want to dispel the fact that we keep referring to COVID as a vaccine. And let's not, everybody needs to remember that the definition of a vaccine has been changed, and therefore that just sends signals to everybody and anybody that there's a problem here. Because my brother is a frontline worker, an emergency room nurse at MTV, was one of the first people to get vaccinated. So people question whether nurses and who don't want to get vaccinated care about their patients. My brother was also one of the first people to not only get the COVID vaccine after being vaccinated, but he also gave it to his entire vaccinated family. So this is a point of view that in hearing you guys talk today, nobody has ever brought up the fact that vaccinated people, especially nurses, are still getting it and giving it. So that's not what I wanted to speak on. I want to speak on HPV and HB 1090, because the fact that 41 states, after Gardasil became available, took it to legislation, 24 actually made a bill. But in 2010, Virginia was the only state to have a mandate And after reading article after article of Marshall's Vought stating that we know it's a requirement, but it's not required, but we still feel it's important to put it on the requirement list. Why? Question mark. And then I found a New England Journal of Medicine article stating that Virginia was one of the original states that agreed that it was not sexually appropriate for children, that there were questions regarding Merck, regarding the legislative process, that they should not have ever gone through legislation. Not to mention that it uses sarin in its development, which you can see in all of the after effects of these children that we are now mandating. So why do we have a requirement that's not required? You have counties after county submitting letters, Colonial Heights being one of them, listing it as a vaccine that is required without the subtext that it's not required. So my question is, your accountability is criminal if these children and these parents who are uneducated followed the lead because Virginia stated it's a requirement that's not required, yet you have county after county in this state submitting it without parents who are not knowledgeable like myself, who don't know to question it, and have now had vaccines that have harmed their children because a state listed it as a requirement that's not required, knowing it's not communicable in the school system. And yet today, 12 years later, there are 3 states and DC that have enacted this. And the question is that what's going on with the other 47 states and why they believe this is not something that deserves to be in their school system?
Your time has expired. Thank you. The next person to speak will be Doris Nick, and we will circle back to see if Mr. Opalski is able to speak after that. Ms. Nick, you are unmuted.
Thank you very much. So there is a silent invisible threat that the VDH has not yet addressed. Nurses in public schools and doctors must be made aware and educated on the fact that scientists are discovering that constant exposure to radiofrequency radiation, even at levels previously thought safe, can have serious and lifelong consequences, especially for children. This is why hundreds of medical and public health professionals from around the world have joined together with parents and professional educators to demand that government agencies adopt more stringent standards to protect children from exposure to RF radiation. Studies show that radiofrequency radiation from tablets, laptops, and Wi-Fi routers are not safe for children. Wireless radiation has been linked to serious health issues. A 10-year study of the National Toxicology Program of the NIH was designed to determine whether non-thermal RF radiation could cause cancer. In 2019, an independent expert panel reviewing the study found clear evidence of increased cancer among the lab animals tested. What illnesses in children are most closely linked with exposure to RFR? The most common illnesses reported from exposure to RFR is electromagnetic hypersensitivity, EHS. It's recognized by the World Health Organization, the U.S. Access Board, Department of Labor, and others. High incidences among children are well documented. Reported medical impacts include neuropsychiatric behavioral effects, anxiety, depression, brain fog, nausea and cognitive impairment, autism, ADHD, childhood leukemia, brain tumors, sudden cardiac arrest, diabetes, and prenatal effects. The available data is stronger with some illnesses than others, although sufficient, even if inconclusive, to justify precaution and further inquiry. The rapid proliferation of wireless devices in classrooms has brought increased concern about the potential health effects of near constant exposure to RF radiation, particularly for children. These concerns stem from multiple factors. All wireless devices emit RF radiation. Multiple devices used in classrooms increase the amount of radiation exposure. Cell phone towers near schools and on school property increase radiation exposure. Wireless devices are not tested in current real-life use patterns. Children are uniquely vulnerable to RF radiation because they're still developing physiology. I'm requesting a formal process to begin to protect children from RFR in schools. Please advise who I can send the research studies and links to be added to this public record. And for more information, you can go to virginiansforsafetech.org.
Ms. Nick, your time has expired. Thank you. We are going to circle back and see if Mr. Opalski is able to speak at this time. I will unmute his line, and if he is able to speak, he can do so now.
Yes, thank you very much. Can you hear me?
Yes, thank you.
Okay, I apologize. The beginning, my microphone wasn't working. I had to use a different device. But anyway, I'm owner of a non-medical home care agency, and I wanted to comment on the proposed existing regulation for a triennial independent audit of our agency's books. And there is a proposed change on today's docket to that. regulation to, I guess, downplay it to more of a financial review. I know that I speak for many other agencies across the Commonwealth because we've talked, especially through our Home Care Association of America, and come to the conclusion we really don't understand the need for this requirement, and we are asking that due consideration be given to removing it from the regulations entirely because we don't understand the cost benefit analysis. Why do we have to have our books reviewed or looked at by an independent auditor? We are in the customer service business of providing care to our clients, and we don't see that this is a tremendous cost and burden for the agencies. We don't understand what the benefit is to either OLC or to the industry at large in terms of better quality care for our customers. So we're asking for consideration to remove regulation, or if it has to stay, could we please get a cost benefit explanation of why it exists and what is going to happen with that piece of paper that we send in every 3 years from an independent auditor that they just looked at our financial statements and they look fine. Because my impression is it's going to be filed away in a cabinet drawer and nothing done with it. I don't think that the OLC has a financial review office that will be delving into that information and trying to figure out how it's going to improve customer care. So that's the extent of my comments.
Thank you, Mr. Opolsky. Madam Chair, that was our last speaker.
All right, thank you very much. Then public comment period is now closed. And excuse me, I'd like to move ahead to our first regulatory action item.
May I just, one question for Dr. Oliver. One of the speakers talking about the risks associated with radio waves threw a lot of information and statistics at us. Does the department have an assessment of whether that is something that merits consideration? I mean,
I don't think it's anything that we've actually made any assessment on. I'm not even sure who would deal with it. Either EPI or maybe Rad Health.
Madam Chair, Mr. Evanson, we do have a Office of Radiological Health. We could possibly put them in touch with this individual, see if there's some initial, at least they can take a look at what she has, because she did go through a lot of information very quickly.
Okay.
And she did ask for us to let her know of a contact person. So we can do that. I don't know exactly if it's in the scope of what we regulate or anything like that, but we can definitely reach out to her.
Thank you.
I appreciate that. All righty, we can move on to regulatory action. Our first regulatory action item, home care organization regs. Rebecca. We're going to get the flash today.
Alex, before we get started, can you check the attendee list? OLC upstairs is dialed in. So it'd be nice to have them join as a panelist in case there are some.
Yes. You need to move closer to the microphone, please.
Any closer and it might be in my mouth.
You might need to take your mask
take your
down
mask
while
off.
you talk. It looks like OLC is on as a panelist, yes.
They are. Okay, thank you.
Is a little bit hard to hear.
Okay. Alex, if you could, through where you're at, unmute them. They've got the Polycom muted upstairs so they can control their own muting with the remote. It's just hard. Thank you. Thank you so much. All right. And please let me know if you can't hear. Madam Chair, I am Rebecca Allen, the Senior Policy Analyst for the Office of Licensure and Certification. I am here to present proposed amendments for 12 VAC 5381, regulations for the licensure of home care organizations. The documents pertaining to this regulatory action were previously provided to you and can be displayed on the screen if you have questions. And I believe in the agenda they're denoted as emergency regulations. These are not. These are just normal proposed regulations as part of the standard 3-stage regulatory process. This regulatory chapter has not undergone a complete standard rulemaking since its original promulgation in 2006, and it needs a thorough review and update. The previously published Notice of Intended Regulatory Action for this action also served as a periodic review of this chapter as required by Executive Order 14, amended July 16, 2018. VDH reviewed and analyzed 3 comments received from 1 commenter submitted during the 30-day public comment period following the publication of the NOIRA, as well as additional comments received after the public comment period, including, I will note, some from Mr. Opolsky, who just spoke with you all. These comments, along with the recommendations of VDH staff based on their experience licensing and inspecting home care organizations, have resulted in the proposed amendments before you today. As a general matter, the proposed regulations before you are aimed at resolving areas of ambiguity that have resulted in frequent confusion for applicants for licensure and conflict between existing regulants and agency staff. Regulatory sections have been consolidated where appropriate, and additional detail, particularly about the licensure and inspection process, have been added. To improve the readability of the chapter, we have been more diligent in following the style guide of the Virginia Register of Regulations, which calls for writing in an active voice and for using subparts to break up long or complex requirements. A driving motivation in revising this regulatory chapter has been the overwhelming growth of the home care industry since the regulations were first promulgated in 2006. The Office of Licensure and Certification receives approximately 350 new applications for HCO licensure each year. This is more new applications than we have total existing licenses for hospitals, nursing homes, or hospice. This volume of new applicants who undergo an initial licensure inspection prior to licensure, combined with our existing volume of HCO licensees who are currently subject to a biennial inspection, and of course complaint inspections, has more than strained the existing staff and resources of the Office of Licensure and Certification. The HCO licensure program is largely fee supported, and fees have not changed in at least 15 years. Additionally, there is no recognition in the current fee structure of the additional resource burden to inspect branch office locations, a concept introduced into the Code of Virginia in 2018. So the proposed fee structure attempts to correct that. At the same time, the Office of Licensure and Certification is mindful of the potential burden to current licensees and new applicants from increased fees. To moderate the fee increase, we are also proposing that the standard inspection interval be changed from biennial to triennial. While the Office of Licensure and Certification would still need additional revenue and staff to service our existing HCO population, a triennial inspection cycle would result in a lesser need than maintaining the biennial schedule and in a less dramatic fee increase. Each inspector on our HCO inspection team can complete an average of 65 inspections annually. By switching to this triennial inspection schedule, we are projecting that there would be approximately 910 inspections per year to be completed, which is inclusive of the initial licensure inspection, triennial inspection, and complaint inspections. This inspection workload of 910 inspections annually would require a total full-time staff of 14 inspectors, 2 administrative staff, and 2 supervisors. Presently, we only have a full-time staff of 4 inspectors, 1 admin, and 1 supervisor, as well as 1 part-time wage inspector. These projections of both workload, staffing need, and fee revenue assume that the regulant population and the new applicant population remain stable. If either population shrinks, there would be less fee revenue, but there would also be a reduced need for additional staff. Though again, it would not completely eliminate the need for additional staff. With that being said, I will dive into the changes that are being proposed by section. We are proposing to rename 12 VAC 5381 to Home Care Organization Licensure Regulation. Section 10, definitions. We have added new definitions in alphabetical order for business day, client, home health services, independent contractor, inspector, legal representative, owner, parent HCO, patient, pharmaceutical services, plan of care, and skilled services director. We have also revised definitions for, again in alphabetical order, activities of daily living, administrator, barrier crimes, blanket fidelity bond, branch office, clinical record, which was formerly client record, contract services, drop site, employee, functional limitations, governing body, HCO or organization, which was formerly home care organization or HCO, home health agency, infusion therapy, instrumental activities of daily living, licensed practical nurse, licensee, medical plan of care, nursing services, OLC, personal care services, physician, which was formerly primary care physician, quality improvement, registered nurse, residence, which was formerly client's residence, skilled services, sworn disclosure, which was formerly sworn disclosure statement, and third-party crime insurance. We've also removed definitions for, in alphabetical order, available at all times during operating hours, chore services, companion services, discharge or termination summary, homemaker services, operator, organization, person, and service area. Section 20, license, has been revised to clarify when the commissioner may issue an HCO license and what disclosures are needed for a parent HCO to add a branch office to its license. We've also revised the text to more closely align with the new, revised, and removed definitions from Section 10. Section 30, exemption from licensure. We've revised to clarify who may be exempted from licensure as an HCO, how to request that exemption, and the obligation to inform VDH if the exemption eligibility is lost. We've also, again, revised the text to more closely align with the Section 10 definitions. Section 30, total geographic area and office location. This is a new section addressing what constitutes total geographic service area, the requirement that HCO offices and drop sites be in a business or commercial zoned building, and that existing HCOs will have 1 year to come into compliance upon the effective date of the regulations. Again, revised as well to come into alignment with the new Section 10 definitions. Section 40, which was previously entitled License Application, Initial and Renewal, we are proposing to rename to Request for Initial License Issuance. Language regarding licensure renewal was moved to a new section, which I will discuss here shortly. We've added language to more clearly identify an applicant's responsibilities when applying for initial licensure, the initial licensure process, when the commissioner may deny licensure, and an applicant's ability to reapply if denied licensure. Again, revised to more closely align with Section 10's definitions. Section 45, license expiration and renewal. This is a new section. Language regarding the licensure renewal was moved here from Section 40 and was modified to more clearly identify a licensee's responsibilities when applying for renewal of licensure, the licensure renewal process, VDH's notification to the Department of Medical Assistance Services, and an HCO's options if it failed to timely renew. Text has been revised, of course, to more closely align with Section 10 definitions. Section 50, compliance appropriate for all types of HCOs. We are proposing to repeal as duplicative. Section 60, which is previously entitled Changes to or Reissue of a License. We are proposing to rename to Surrender of License, Material Change of License. This has been revised to clarify what is a material change to a license and to clarify an HCO's obligations and the process to obtain a changed license. The revised text has been more closely aligned with Section 10 definitions and also incorporates the requirements concerning the return of a license that were previously found in Section 140. Section 65, license reinstatement. This is a new section that creates a new reinstatement licensure process by which an HCO that failed to timely renew its license prior to expiration can apply for reinstatement of license rather than obtaining a new one. Section addresses an HCO's responsibilities when applying for reinstatement licensure, the reinstatement licensure process, when the commissioner may deny licensure, and an HCO's ability to reapply if denied licensure. Section 70, fees. The fees have been revised to reflect the increases in operating costs since the last revision at least 15 years ago, including the additional burden of inspecting branch offices, which were introduced in 2018. It clarifies that fees are non-refundable and again, revised to align with Section 10 definitions. Section 80, on-site inspections, revised to more clearly explain the on-site inspection process and HCO's obligations during and after the inspection, and incorporates the home visit requirements from Section 90. It also decreases inspection frequency from biennial to triennial, and overall, the text has been revised to more closely align with Section 10 definitions. Section 90, home visits. This section we are proposing to repeal as we have incorporated its requirements and consolidated them with Section 80. Section 100, previously entitled Complaint Investigations Conducted by the OLC, renamed to simply Complaint Investigations. Revised to give VDH discretion to determine if an on-site inspection is necessary for a complaint investigation, subject to the criteria identified, and to specify an HCO's obligation to cooperate in this determination. The text has been revised to more closely align with Section 10's definitions. Section 105, Plan of Correction. This is a new section that consolidates the plan of correction language found in sections 80 and 100 to ensure that the plan of correction process is consistent across all occurrences. Revisions include clarification that an HCO or an applicant for licensure does not have unlimited opportunities to revise unacceptable plans of correction. Section 110, Criminal Records Check. This has been revised to reflect statutory language about mandated criminal records check, including language on how HCOs can satisfy this requirement when utilizing staff from temporary staffing agencies or independent contractors. Again, revised to more closely align with Section 10 definitions. Section 120, previously entitled Variances, we are proposing to rename to Allowable Variances. The text has been revised to reflect that the state health commissioners who is empowered to grant variances, to clarify that what the variance request process is, and to more closely align with Section 10. Section 130, previously entitled Revocation or Suspension of a License, we are proposing to rename to Violation of this chapter or applicable law, denial, revocation, or suspension of a license. We've revised this text to match statutory provisions and again to more closely align with Section 10. Section 140, Return of a License. This section we are proposing to repeal as we have taken its requirements and consolidated it with Section 60. Section 150, Management and Administration. Revised text to more closely align with Section 10 and to remove duplicative subsections that we have addressed now in prior sections. Added language to the section that HCOs have to document in writing who can act as their agent in transactions with VDH. Section 160, Governing Body, again revised to align with Section 10. We've added language to require the governing body to have a written organizational plan and bylaws, including minimum requirements for the bylaws. Section 170, Administrator, revised for clarity and to align with Section 10. Section 180, previously entitled Written Policies and Procedures, renamed to simply Policies and Procedures. Revised text to more closely align with Section 10, and we have revised it quite extensively to consolidate requirements for the policies and procedures into a single section of our regulations and to increase the review interval from 1 year, decrease the review interval from 1 year to 2 years. We have revised the text to clarify ambiguities, incorporate relevant statutory and regulatory references, and to add more specificity to the infection prevention policies and procedures that were previously found in Section 260. Requirements for pharmaceutical services, policies, and procedures have been moved to this section from Section 350. Section 190, Financial Controls, again revised to align with Section 10. We've also revised this text so that HCOs would obtain a review by an independent certified public accountant rather than the audit requirement that is there presently, and that HCOs are required to notify VDH if they are subject to a Medicaid fraud investigation. Section 200, previously named Personnel Practices, renamed to Employee Practices. Revised to align with Section 10 and to clarify that job description requirements apply to all workers, whether compensated or not, whether employed or contracted. Revise the text to require orientation to include fraud, abuse, and neglect training. Section 210, Indemnity Coverage, again, revised to align with Section 10 and to reference professional liability insurance instead of malpractice insurance. Revised text to remove statutory reference and replace with coverage minimums that increase annually. Section 220, Contract Services. This was a simple revision to align it with Section 10. Section 230, previously entitled Client Rights, we are proposing to rename to Client and Patient Rights. Revised text to more closely align with Section 10 and to more closely align with the rights language for home health agency patients at the federal level. Section 240, previously entitled Handling Complaints from Clients, renamed to simply Complaint Handling Procedures. We've revised it to more closely align with Section 10 and to expand complaint record retention from 3 to 5 years. Section 250, Quality Improvement. This was a revision for clarity and to align with Section 10. Section 260, Infection Control, revised to align with Section 10 and to add requirements for an employee health program. And the infection control activities that were previously here in 260 were moved up to Section 180. Section 270, Drop Sites. This was a simple revision to improve the clarity and to align with Section 10. Section 280, previously entitled Client Record System, renamed to Clinical Record System. Revised to align with Section 10 and for improved clarity, and revised to address what a medical plan of care or simple plan of care should include. Section 290, home attendance, revised to align with Section 10, and to remove reference to obsolete training curriculum, which has been replaced with a training program that an HCO may offer its home attendants and volunteers instead. Section 300, skilled services, revised text to more closely align with Section 10 for improved clarity and to specify that pharmaceutical services are a type of skilled services. Section 310, nursing services, again, revision to align with Section 10 to correct a regulatory reference and to specify that supervision should be at least every 60 calendar days. Section 320, therapy services, revised to align with Section 10 for improved clarity and to specify that supervision should be in alignment with the Therapy Licensing Board standards. Section 330, home attendants assisting with skilled services, revised to align with Section 10 for improved clarity, to correct a statutory reference and to specify that home attendants should be supervised in person at least once every 60 calendar days. Section 340, medical social services, revised text to more closely align with Section 10 definitions for improved clarity and to reduce the minimum experience needed for the licensed clinical social worker or the individual who has a master's degree in social work. Section 350, previously entitled pharmacy services, we are proposing to rename to pharmaceutical services. And this has been revised to more closely align with Section 10 and to remove the policies and procedures to Section 180. And then the documents incorporated by reference section, we are proposing to repeal that as there are no longer documents incorporated by reference in the proposed regulatory text. With all that being said, should the board approve these proposed amendments, they will be submitted for executive branch review, which includes review by the Office of the Attorney General, review by the Department of Planning and Budget for its economic impact, review by the Secretary of Health and Human Resources, and review by the Governor's Office. After completion of the executive branch review, the proposed amendments will be published in the Virginia Register of Regulations and on Virginia Regulatory Town Hall for a 60-day public comment period. Following the close of that public comment period, VDH will present a final draft of the regulations to you for your consideration and approval at a future board meeting. Madam Chair, I recommend that the board approve the proposed amendments to the regulations for licensure of home care organizations.
Thank you very much. All right, first of all, let's get a motion on the floor before open for questions. Do I have a motion to approve 12 VAC 5-381?
I so move.
Can we have a motion? Dr. Klein, we have a second. We have a second by Ms. Whipple. We have a motion and a second. Open for questions, comments, or concerns. Jim.
131 pages is a lot. Which of these items listed in those 131 pages are most likely to be disruptive to the practices now of the people who are involved in this industry, perhaps like the gentleman who made some comments? And what do you consider to be controversial things that we ought to be aware of?
Well, I don't want to put words in anyone's mouth. I will definitely take my best guess at what may be controversial or a particular burden. As I mentioned in my, I admit, rather lengthy opening remarks, certainly the fee increase, since it hasn't been changed in at least 15 years, as far back as my records go, I anticipate that that will be the subject of some comment because it is a pretty substantial increase. In terms of the changes to existing operations, we are hoping that to Mr. Opolsky's point about the audit, and he's not the only public commenter that mentioned it. We're hoping that by stepping that down to a review instead of an audit, that it will still achieve the purpose that we are going for while reducing the burden to those agencies. I think the majority of what we have here is aimed at making it less cumbersome for them to operate. I know we have strengthened some of the infection control policies and procedures that may be the subject of some pushback, but I think this pandemic has certainly demonstrated the need for stronger and more specific requirements regarding infection control. I do think also that there may be some comments received about the supervision interval for skilled services, because right now it is 90 days. With the exception of the one that's for the licensing board, and we're saying to drop it to increase the interval to 60 days. I will say the one for the massage therapist, they have their own licensing board that addresses the survey interval. So or not the survey, excuse me, the supervision interval. So we defer to them on what would be an appropriate supervision interval. But for the nursing requirement or supervision of nursing, there is no requirement the Board of Nursing has set. So we have set it at 60. So I would say that's probably going to be the subject of some comment as well.
Yeah, the one that jumped out at me was that very one.
Yeah.
Having to do on-site visits, presumably, by supervisors every 60 days. That I have no idea what the norms are now, but if somebody's got 100 people who are out providing services, every 60 days seems like a lot. I don't know.
I thought someone was speaking.
Ms. Whipple? I'm sure. I had actually the opposite reaction, that if you have a caregiver in your home, versus checking to make sure they're doing it properly, less than that, I think would be inadequate.
Could very well be the case. I mean, I'm speaking from ignorance, but I know that's going to mean
Yes.
potentially a lot of additional supervisors.
And I will note that the supervision interval going from 90 to 60 is for the skilled services. It is not for personal care services. So that interval stays as it is now, which is 90 days. The skilled services, and if any of the folks upstairs at the Office of Licensure and Certification want to chime in, when a patient is receiving skilled services, they have to be assessed when they're first brought into care by that home care organization. And then there are periodic reassessments thereafter by the registered nurse. And those periodic assessments have to be done in person anyway. So those things can be combined in a single visit. Madam Chair.
I have two questions. One is on section 180, written policies and procedures. So if you take out written, I guess, could they have policies and procedures that are not written? I know that sounds like a stupid question, but
no, that I take the point well. So we the actual requirement is the text of the regulation, not necessarily its title. And we do say, if you all are looking at I believe it's the correct version. I think it's line 1055. So page 24, line 1055, or 1054 and 1055. A governing body shall approve and maintain documented policies and procedures, which I'm skipping over some things here, which shall be readily available on the premises of the parent HCO's office and all branch offices. So there is a requirement that they are documented.
they are documented.
Yes.
Okay. And then the other question is with the review process, I'm not sure I understood what he was saying the same thing as the biennial, now triennial?
No, so
inspection.
Mr. Opalski was speaking to an existing requirement in the regulations, and the financial control section, which I believe is 190. One moment, I'll make sure of that. Yes, 190, which starts on page 28, line 1238. So there is a requirement currently in our regulations that every 3 years, HCOs are supposed to have an audit conducted by an independent certified public accountant. That audit requirement of their financial records is separate from and different from the inspection procedures.
Okay.
Yes.
So this audit requirement is a new requirement.
No, so the audit requirement exists now.
Okay.
Today.
Okay.
But what we are proposing is to move from an audit by an independent CPA to a review by an independent CPA. So,
well, that's actually better than an audit, isn't it?
No, audits are the most stringent of the assurance procedures that a CPA can do. So if you think of it as a pyramid, you have audit at the top.
Yeah.
Then you have review.
Right.
Then you have compilation, and then you have preparation of financial statement services. The bottom two, compilation and the preparation of financial statements, that is something that does not require independence by a CPA. review and audit does require that the CPA be independent of the organization that they are reviewing or auditing.
So I just want to make sure I'm clear. So right now you require an audit
Yes.
and you're changing it to require a review.
Yes.
And the review is not as stringent as an audit.
That is correct.
So
Anita,
it's
I know
actually,
this is awkward, but I don't think everybody can hear you.
Oh,
because
sorry.
Steve's over there and your mic's
Sorry.
over there.
so the review would potentially cost less than the audit because it's not as in-depth.
Potentially, yes. I mean, we don't have control over the prices that CPAs charge for their
Right.
services, but the audit is, the most stringent service that they
Right.
can provide in terms of reviewing paper or the financial papers of an organization.
So you're actually making a change that would make it easier, not easier, but less cost burden potentially. So I'm not sure I understand his public comment.
I can speak to that, at least from personal experience, because I have the same kind of rules that I have to deal with getting audited. Audits are more expensive, but you can't have an every third year audit. A responsible CPA won't give you an audit every third year if he doesn't know what's happened the previous 2 years. And frankly, the same thing is true of a review. It's less stringent. There's less formal reviewing of transactions, but I doubt the viability of either. It's the information that you get is going to be sketchy at best if all you're looking at is every third year.
Thank you.
Are there other? Ms. Whipple, you look like you're about to say something.
One of the things that was asked for and that you mentioned was that you thought the review would fulfill your purpose in requesting the information. So what is the purpose?
So the reason why, and I gave the example of the pyramid of the different services that a CPA can provide. The reason why we felt that the review would still be appropriate is it does have that independence level. That is, the CPAs have to be independent. That's their professional requirements. The purpose we're aimed at of the audit now and potentially the review in the future if these amendments were successful is that one, to ensure that there are adequate financial controls in that organization. And also there is an issue with Medicaid fraud. So we do not, we don't investigate Medicaid fraud. That's not our silo to work in. When we're going and doing our inspections, we're looking at compliance with the regulations. I believe, and Robin Kurz can correct me, the Office of the Attorney General is the one who has the Medicaid fraud investigation unit, correct? Yes. So to the extent that our requirements could potentially flag potential or ongoing Medicaid fraud, we would want to share that with our partners and other state agencies. Additionally, there has been discussion this year at the Joint Commission on Healthcare. They did a study on aging in place. And one of the recommendations that they made is that, which they did endorse, was to pursue a budget amendment to expand Medicaid services to include compensation for personal care services. So right now, Medicaid, home care organizations that are receiving Medicaid dollars, they're doing skilled services. If they're doing personal care services, Medicaid won't cover that. If the budget amendment is ultimately successful, then that's going to be expanded to personal care services. So a lot more of our HCOs potentially could be receiving Medicaid reimbursement. So we think it's important to retain that there to help catch Medicaid fraud before it gets too far down the road and starts costing the Commonwealth even more. So.
All right. Are there any other questions, comments? All right. Then all those in favor signify by saying aye. We're doing a roll call, right, Alex? So all those in favor signify when Alex calls her name.
Thank you, Madam Chair. Mr. Kreitzer?
Yes.
Oh, I'm sorry, Mr. Kreitzer. Could you do that one more time?
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Hines? I know she actually had to step out. Okay. Ms. Harrison? Thank you. Dr. Klein? Thank you. Dr. Miller? Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Peretz?
Yes.
Thank you. Ms. Ramos?
Yes.
Thank you. Dr. Schuler? I can see you say yes.
I can see him saying yes.
Dr. Swartz?
Yes.
Thank you. And Ms. Whipple? Thank you. Madam Chair, the motion has 11 votes for the motion to adopt.
All right. Thank you very much. Thank you, Ms. Allen.
All right, thank
We
you.
could move on to Dr. Peak for disease reporting and control regulations. Lillian, I've been having a little trouble hearing you today, so if you could just speak up as loudly as possible.
Okay, how's this?
I can't
Good.
tell yet.
Okay. Good afternoon, Madam Chairman and members of the board. As Dr. Oliver noted earlier, I'm Dr. Lillian Peak, Director of the Office of Epidemiology. I'm here today to present proposed amendments to the disease reporting and control regulations in 12 VAC 5. So these proposed amendments will bring the regulations for disease reporting and control into alignment with recent changes in the field of applied communicable disease epidemiology. They're aimed at protecting the health and safety of Virginians by improving our ability to conduct surveillance of infectious diseases in Virginia, which in turn enables the Commonwealth to implement strategies to reduce the impact of outbreaks. This proposed regulatory action removes, edits, and adds several definitions as necessary to reflect current public health practice and needs. It removes the requirement for physicians to report weekly counts of influenza diagnoses. It modifies the timelines for laboratories to submit isolates or specimens for a subset of conditions to DCLS or other public health laboratory for further testing, and that's to improve timeliness and the viability of the material available for testing. It adds ethnicity to the demographic information that's required to be reported. It replaces reporting by use of an EPI-1 paper form with reporting via an online web portal. And it modifies the section on the federal select agent program to clarify that VDH requires an annual report and an immediate report of a loss, theft, or release of a select agent. There are other minor changes to these regulations, and they're listed in the town hall document under detail of changes. So this regulatory action was originally presented as a fast-tracked action in 2019. However, after publication in the Virginia Registry of Regulations, we did receive more than 10 comments objecting to the use of the fast-tracked action. The majority of the commenters objected to VDH receiving reports of their influenza diagnosis, which includes personal information. So the proposed regulatory action related to these comments does not actually add any influenza reporting requirements. The amendment is intended to clarify that physicians no longer need to report a weekly number of all influenza cases and are only required to report laboratory confirmed influenza cases. Should the board adopt these proposed amendments, they will be submitted to the Virginia Regulatory Town Hall to initiate the executive branch review process, which consists of review by the Office of the Attorney General, Department of Planning and Budget, Secretary of Health and Human Resources, and the governor. Following approval by the governor, they would be published in the Virginia Register of Regulations for a 60-day public comment period, after which VDH would bring the final amendments back to the board for consideration at a future meeting. Madam Chair, I recommend that the Board of Health approve these proposed amendments to the regulations for disease control, reporting and control. Thanks.
If we can have a motion and a second to get this on the floor, and then we can open for discussion.
I so move.
Motion from Ms. Whipple, second from Dr. Miller. All right, questions, comments, concerns? Jim?
Dr. Peak, would you remind us again of where these lists of reportable diseases by the various parties are derived? Is this something that's just been put together by VDH, or has it come from some sort of a standard list from CDC or other federal institutions?
Yes, at CDC or at the national level, there is a list of notifiable conditions, and VDH works with other states through the Council for State and Territorial Epidemiologists in CDC to review potential additions to the national notifiable conditions. And we also review those in Virginia to determine whether or not we want to adopt them in our regulations. So there is a standard of a set of conditions that are reported across the country.
Okay, I'm not sure I understood everything that you just said, but are there any diseases in these lists that are uniquely required by Virginia as opposed to the CDC or some other entity?
That's a good question. I'd have to go back and look. I think the one, it's actually not in the change for regulations today. So there's nothing that we're presenting in the regulatory changes today that actually adds anything to the list of reportable conditions.
Okay. I noticed in one of the sections, it becomes sort of open-ended. It says that the VDH may require additional diseases. Does that require a regulatory process, or is that something that the commissioner can just tell people, okay, we've now got this new disease that you have to report?
So there is, just pull up, hang on, let me look at that first. Pull up the actual list. There is, one of the conditions is unusual occurrence of diseases of public health concern. And that is something that the commissioner can determine is an issue, like, and needs to be reported. But that is not in the change or in the regulatory action today. As I said, there's nothing in this list. We're not adding or taking anything away from the actual list.
Does that take care of your question? Okay. All right. Is there anything? I think Norm was first and then Wendy.
Dr. Pika, on the adding of ethnicity as a required fill, is that, I know that there are some things that these are just the changes and not the stuff that already exists in the regulations. Racial categories are already in as a required field?
Yes, they are.
Okay.
Wendy?
Question, please, Dr. Peak. How is influenza tracked in Virginia? How is it monitored?
Sure.
Because I see you've taken away this requirement, so obviously there must be some other way that you're monitoring the case counts.
Yes. So we really have two goals in influenza surveillance. One is to make sure that we're monitoring the magnitude and the trend.
I'm sorry, I can't hear you. Can you speak up?
Yeah, is this any better? How's that? I'm going to let me know if this helps. Is that better?
Yes, I think so.
Okay. So we have two goals with influenza surveillance. One is to monitor the trends and the magnitude of seasonal influenza outbreaks. And we do that through our influenza-like illness surveillance system. So in Virginia, we have a very, very strong syndromic surveillance system. And we collect information from all of the emergency departments in Virginia and many of the urgent care centers. And so they report information to us on different syndromes, including influenza-like illness, and that provides that the capability. And that's why we don't need to have those weekly numbers of reports. Our syndromic surveillance is actually a much stronger indicator. We do, however, need to understand the number of confirmed cases, and we participate with the National Influenza Surveillance Program so that we can identify changes early on if there were any kind of mutation that could lead to a new influenza virus. Then we still need those confirmed cases so that we can monitor that. So we do both, and that's how, and it works very well.
Thank you.
Are there other questions? All right, then Alex, if you wouldn't mind doing a roll call, please.
Absolutely, Madam Chair. Mr. Kreitzer?
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Harrison? Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller? Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Puritz?
Yes.
Thank you. Ms. Ramos?
Yes.
Thank you. Dr. Schuler? Thank you. Dr. Swartz?
Yes.
Thank you. And Ms. Whipple? Thank you. Madam Chair, there are 11 votes to adopt the motion.
Thank you very much. So we will move on to the 12 VAC 5610 fast track amendments for sewage handling and disposal regulations. Dr. Deegan.
Thank you. Madam Chair and members of the board, I am Marcia Dagan, Technical Services Manager with the On-Site Division in the Office of Environmental Health Services, and I'm here today to present fast track amendments to the sewage handling and disposal regulations. The sewage handling and disposal regulations address the design and installation of on-site sewage systems utilizing septic tank effluent. Septic tank effluent is raw sewage that's treated only to remove solids, fats, oils, and greases by passing through a septic tank before release to a soil dispersal field or drain field. Higher quality effluents produced through aerobic biological treatment are referenced, but the regulations currently provide very limited details on design and installation specifications for those types of systems. The Fast Track Amendment will codify minimum design and installation criteria for pump stations and soil dispersal areas utilizing treated effluent, also called treatment level 2 or treatment level 3 type effluent. These types of designs were historically addressed through product-specific approvals beginning in 1995 and culminated in a comprehensive policy in 2009, GMP 147. This policy included procedures for treatment units to receive general approval, hydraulic loading rates to soil, design criteria and installation criteria for soil dispersal systems receiving treated TL3 effluent only, and waived pump station design criteria for certain uses of pumps and pump stations. This policy, GMP 147, was rescinded following promulgation of another regulation, the Regulation for Alternative On-Site Sewage Systems, or the AOSS regulations. However, the AOSS regulations are performance regs, and therefore they did not include the specific design and installation criteria that were found in the policy GMP 147. To address this gap, the Virginia Department of Health issued a policy in 2016, which noted that licensed professionals could continue to use the design guidance from the rescinded policy, provided the design also complies with the AOSS regulations. Parts of that policy, parts of GMP 147, are superseded by the AOSS regulations. So there's extraneous information in the GMP that makes it confusing as a definitive reference. The purpose of this fast track amendment is to codify those minimum design and installation criteria for pump stations and soil dispersal areas utilizing treated effluent, to resolve the confusion, and to provide clear design instruction to licensed professionals in Virginia. VDH began working with both internal and external stakeholders in December of 2020. Internal stakeholders were engaged through presentation and discussion at routine environmental health manager meetings. External stakeholders were included through the Sewage Handling and Disposal Regulation Advisory Committee, or SHADAC. SHADAC represents over a dozen on-site wastewater stakeholder groups, such as the Virginia Society of Professional Engineers, the Virginia On-Site Wastewater Recycling Association, the Virginia Association of Professional Soil Scientists, and the Virginia Environmental Health Association. Beginning in December 2020, VDH took the draft regulation to SHADAC and further clarified the language based on their feedback to ensure support. Each draft and related comments were posted on the VDH website. The SHADAC meeting summaries with relevant discussion are posted on Town Hall. VDH made multiple presentations and created multiple drafts and presented to the environmental health managers and SHADAC, as well as to the Virginia On-Site Wastewater Recycling Association and Virginia Environmental Health Association. The fast track amendments seek to incorporate elements from GMP 147 with appropriate revisions based on discussion with our stakeholders. The fast track amendments fall into 4 categories. First is definitions. 6 definitions were added to facilitate the update, such as definitions of treatment level. 4 were carried over from the AOSS regulations, so they were copy and pasted, and 2 are new, which are for infiltrative surface and working volume. There are a series of procedural changes, such as a reference to the limits of design for licensed on-site soil evaluators, and this is to parallel Code Section 54.1-402A11, which is essentially a DPOR requirement. And it also eliminates the need for formal plans for designs that fall within that category. There's a number of minor updates, a number of minor wording changes that were made in the affected regulatory sections as agreed upon by stakeholders, such as updating the technical language on how to characterize a seasonal water table with the addition of the term redoxymorphic, and specifying the physical location of control panels to facilitate access, and updating internal references due to the modifications. And then the last group is the technical modifications, and they focus on the pumps and pump stations handling the treated effluent and on the design criteria for the various dispersal methods utilizing our treatment level 2 and treatment level 3 effluent. These criteria clarify relief from certain provisions in the existing sewage handling and disposal regulations, relief currently provided through GMP 147 in recognition of the higher quality effluent. With regard to the technical modifications, the amendments accomplish the following. The amendments waive the general pump station requirements for pumps that are internal to a treatment unit, as they do not have the same function as pumps that convey effluent to a dispersal field. Pump stations that do convey effluent to a dispersal field are required to meet design criteria that add to the station's functionality and reliability, such as emergency storage, alarms, shut-off valves, and check valves. The minimum velocity in a force main is reduced to 1 foot per second from 2 foot per second, which will provide more flexibility to designers and is justified due to the lower solids content of the wastewater. The amendments establish effluent loading rates to the soil for treatment level 2 and treatment level 3 effluent for the 4 available dispersal types. GMP 147 only had loading rates for TL3 effluent, and the AOSS regs have very broad loading rates for the treated effluent. The updated table provided in the amendments provides a more detailed descriptive criteria for the designers. And then design criteria for trenches, pads, and mounds receiving TL2 and TL3 are provided. For trenches and mounds, the amendments provide clarity on minimum trench depth, minimum sand depth, soil cover, and loading rates. And then pads are a new dispersal method only found in GMP 147. So design criteria are added from the policy, but they are also modified to allow for a mix of different dispersal methods in a system, to remove the maximum size of a pad that was limited in the policy, and to clarify that pads must be dosed at a minimum. The amendments before you today will provide clarity between the criteria in policy and the regulations, provide clarity to both internal and external clients, will reduce processing times due to the clear requirements, and maintain clear design authority to all licensed professionals. If approved by the board, the amendments will be submitted for executive branch review. Upon approval by the governor, the amendments will be published in the Virginia Register of Regulations. Following publication of the amendments, the public comment period will open for 30 days on Virginia's online town hall. The regulations will go into effect 15 days after the close of the public comment period, unless an objection is received from a member of the applicable standing committee on the House of Delegates or Senate of Virginia, a member of the Joint Commission on Administrative Rules, or from 10 or more members of the public. We have worked carefully with stakeholders to reach consensus on the amendments and believe that these points of clarity should not be delayed for 3 or 5 years to go through the standard regulatory adoption process. Madam Chair, I recommend that the board approve the fast track amendments to the sewage handling and disposal regulations.
Thank you, Dr. Dagan. Can we get a motion and a second on the floor for 12 VAC 5-610? Dr. Puritz makes a motion. Who is the second? Dr. Klein is the second. All right, comments, questions, concerns? Jim, I knew you couldn't let it go.
It's this question relates to how long I've been around. The most controversial thing we dealt with in the pre-2010 era was sewage disposal. Believe it or not, did all of the ferment that resulted from that time, is that really what preceded GMP 147, Joe, or am I fuzzy in the extreme?
So, Madam Chair, members of the board, I think what you're actually referring to, Jim, is the biosolids regulations, which is separate from this. The biosolids are now, responsibility for that was transferred to the Department of Environmental Quality several years ago. So we are out of that. This is separate.
Any other questions, comments, concerns? Ms. Whipple?
So I think it's really good to try to get consensus among the stakeholders, but it makes me a little nervous that there were 6 drafts. So I just would like to be assured that the public health interest has been maintained even through the 6th draft.
Yes, ma'am. A lot of it was to fine tune the wording to ensure that it said what we thought it said. As we tried to describe some of these systems, some of our stakeholders were getting a different picture in their mind. So a lot of it was finessing that language. The main components of the things that drive public health protection are the loading rates and the effluent quality, and those remain unchanged through those 6 different drafts.
Thank you very much.
You're welcome.
Ms. Whipple, I will just say, as someone who has been in local elected politics for over 20 years, if there is anyone who is more dogmatic about getting it right than public health officials, it's sewer people. I promise you. All right. Are there any other questions, comments, or concerns? All right. Could we have a roll call vote, Alex, please?
Yes, Madam Chair. Mr. Kreitzer?
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Harrison? Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller? Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Puritz? Thank you. Ms. Ramos?
Yes.
Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Swartz?
Yes.
Thank you. And Ms. Whipple? Thank you. Madam Chair, there are 11 votes for the motion to adopt.
Thank you. Ladies and gentlemen, I'll just let you know that I have had a small crisis at my place of work. And if at 1:45, I'm going to ask Dr. Miller to take my spot, but we should be mostly done by then. Just wanted to let you know if I disappear, that's why. So if we could then move on to 12 VAC 5-71, regulations governing Virginia newborn screening service, final amendment.
Good afternoon,
Heather.
Yes.
Hi.
Good afternoon, Madam Chair.
We can't hear you at all.
Good afternoon, Madam Chair. Is this?
Heather, you need to move closer to the microphone.
Good afternoon, Madam Chair and members of the board.
Sorry, Heather, we still can't hear you. Give us just a second. We'll see if we can work with it on our end a little. Sounds like you're at the end of a very long train tunnel. Okay.
Good afternoon, Madam Chair and members of the
better.
Okay, great, wonderful. Apologies for that. I'm Heather Borg, the Acting Director of the Office of Family Health Services. Today, I'm presenting the board with final amendments to regulations governing Virginia newborn screening services.
I can't understand a thing.
I'm sorry. We just can't hear you. I can't hear you either one. Sorry.
Call in.
Maybe.
Yeah, Heather, you might try dialing in on the phone and using your phone for your audio.
Okay.
And turn off your computer mic.
Great idea.
Heather, if you go down in your WebEx window where it says mute, there's a little caret that says audio options. You should be able to click that and do switch audio. And one of the options will be to call you, and you can tell it what number to call, and then it will just merge the audio and switch your audio to your phone. Okay. And then I have forwarded you the panelist information to dial in on your phone. Heather, I can see you talking on your video, but we can't hear you. You're muted. I'm going to unmute you. You're unmuted now.
Okay.
Muting you because it looked like you were calling. We cannot hear you, no. I think you are, hang on, okay. Caller 13. Okay, so I've identified you on the attendee list and I can unmute you. You need to disable your computer microphone or we're going to get an echo the whole time. We can't hear you. I think you are, I've unmuted you.
Are you able to hear me at this point?
You sound very far away. The phone was working. It was just that because your computer microphone was enabled and you were connected to the WebEx audio through your computer and through your phone, you can't do both. So if you disconnect your audio on your computer, then the call-in should work.
Okay, I will try that again.
Heather, I can still see that your computer audio is connected in the WebEx event. So that little caret with the audio options, when you click on that, there should be one that says switch audio, right? I think the only way might be to do this would be for me to expel you as a panelist so that we can at least hear you, but you won't be able to see what's on the screen. Oh, hang on, John's coming over.
Heather, I think the best solution is like leave and come back and join as a panelist. And then right when you're clicking the join the meeting button in the center bottom of the screen, they'll have like the video and audio options. And one of them will be the audio option. And at that point, you can select the option to like disconnect your computer audio. So then when you come back in, you can use the phone thing.
Okay, I apologize. I thought I had everything.
Now we can hear you.
But this audio is great.
Okay, well, let's see. I very much apologize for this. All right, I've continued to not connect with my audio.
We can hear you.
Okay, I am comfortable proceeding by phone if all can hear me okay.
Yeah, that's fine.
Okay, great. Again, apologies, Madam Chair and members of the board. I'm Heather Board, the Acting Director for the Office of Family Health Services. Today, I'm presenting the board with final amendments to the regulations governing Virginia Newborn Screening Services, 12 VAC 5-71.
Section 32.1-65 of the Code of Virginia authorized the requirement to conduct newborn screening on every infant in the Commonwealth of Virginia. Section 32.1-67 of the Code of Virginia requires the Board of Health to promulgate regulations as necessary to implement newborn screening services. The regulations are required to include a list of newborn screening tests pursuant to Section 32.1-65. The Virginia Newborn Screening Program aims to prevent intellectual disability, permanent disability, or death through early identification and treatment of infants who are affected by certain hereditable disorders and genetic disease. The Division of Consolidated Laboratory Services, the Virginia Department of General Services, conducts the newborn dry blood spot screening test in collaboration with the Virginia Department of Health. The benefits of the Virginia Newborn Screening Program are as follows. Makes it possible to find out whether newborn babies have disorders that may result in serious problems if treatment is not started soon after birth. Every newborn in Virginia is tested 24 to 48 hours after birth unless a parent or guardian objects because the test conflicts with their religious practices. VDH newborn screening nurses coordinate follow activities until the infant is diagnosed, screened negative, or reaches 6 months of age. Babies who are diagnosed with certain hereditable disorders and genetic diseases through newborn blood spot screening are referred to Care Connection for Children for care coordination services. The rationale for adding 2 disorders to the Virginia Newborn Screening Panel are as follows. Spinal muscular atrophy, referred to as SMA, is a genetic disorder characterized by weakness and wasting, or atrophy, in muscles used for movement, the skeletal muscles, and affects about 9.1 out of every 100,000 births. X-linked adrenoleukodystrophy, referred to as XALD, is a genetic disorder that occurs primarily in males, mainly affecting the nervous system and the adrenal glands, and affects 6 out of every 100,000 births. The additions of SMA and XALD to the newborn screening panel have been recommended by the Virginia Genetics Advisory Committee. On the national level, these disorders have been added to the core panel of 35 genetic disorders included in the recommended uniform screening panel of the U.S. Secretary of Health and Human Services Advisory Committee on Hereditable Disorders in Newborns and Children. Current regulatory provisions for the Virginia Newborn Screening Program are contained in regulations governing Virginia Newborn Screening Services, 12 VAC 5-71. VDH is requesting the board's consideration to amend the existing newborn screening regulation to add SMA and XALD to the newborn screening panel. Approval of this regulatory action would result in amending 12 VAC 5-71 to revise Section 30, which lists the specific disorders and genetic diseases that must be screened in Virginia. Currently, there are 33 hereditable disorders and diseases on the Virginia Newborn Screening Panel. The addition of SMA and XALD will align Virginia's newborn screening panel with the national RUSP. All Virginia newborns would be screened for SMA and XALD at birth. The primary advantage of the proposed regulatory action is that screening for SMA and XALD can provide affected infants the benefit of early diagnosis and treatment. These disorders cannot be detected at birth through a physical examination. The main disadvantage to adding these screenings is the increased cost. Startup or operating costs for both SMA and XALD will be incurred by DCLS and will be supported by the fee increase for the blood spot screening panel that went into effect October 2019. The current fee is $138. The newborn screening fee was increased to $138 from $101 per infant in October 2019 in preparation for SMA and XALD implementation. Adding SMA to the newborn screening panel resulted in an increase of $2.16, and adding XALD to the newborn screening resulted in an increase of $10.84 per sample, for a total of $13 for both of these disorders. An additional $24 was also included in the fee increase to support the implementation of CCMV testing, as well as other NBS laboratory and follow-up operational expenses. Following publication of the prior proposed regulation in the Virginia Register of Regulations, the 60-day public comment period resulted in 64 comments from various parties in support of the proposed regulatory action. Recommendations were received from one commenter representing the Virginia Hospital and Healthcare Association. The commenter expressed concerns regarding cost increases for current and future newborn screening expansion. VDH concurs that this regulatory amendment and associated fee increases to DCLS's dried spot specimen kits potentially results in an economic impact to hospitals, birthing centers, midwives, and infants and their families. However, the fee increase for adding SMA and XALD already went into effect in October 2019 in preparation for the implementation of these two disorders. The commenter also recommended that the regulatory language be amended to limit DCLS's authorization to establish fees or implement increases to fees. The regulation is currently undergoing periodic review, and a stakeholder work group of the Newborn Screening Advisory Committee will review the regulation and make suggested amendments. The regulation to amend 12-VAC5-71-100 will be put forth for consideration during the regulatory process. Finally, the commenter recommended that future costs to add newborn screening disorders to the panel could be absorbed by DCLS. VDH does not concur with this recommendation and will follow the established process for developing and submitting a budget proposal request for a General Assembly appropriation for costs related to adding new disorders to the newborn screening panel in accordance with the regulation and when required. Should the board approve the final stage regulatory action, the proposed amendments will be submitted to the regulatory hall to begin the executive branch review process, consisting of review by the OAG, DPB, Secretary of HHR, and the Governor. Madam Chair, I recommend that the board approve the final stage regulatory action.
Thank you, Heather. We try again. How's that? All right. Thank you, Heather. You did a great job. Do I have a motion to approve these amended regulations? Holly? So, okay, second? Okay. Are there any questions or discussion?
So I just had one question that I wasn't clear about. You said the fees have been in place since 2019. I was a little bit confused about what you said about the fees, the $13.
Yes, that is correct. In preparation for these two conditions being added, action was taken to increase those fees already, and they went into effect October of 2019.
So I'm confused. If we've collected that amount of fees but have not done the test, is that a normal procedure, or am I missing? Where did those dollars go if they weren't used to do the actual test?
Okay, And we have Jennifer McDonald, who is the director of the Division of Child and Family Health, who can speak more directly to that question.
Thank you.
I am here. Can you hear me well?
Luckily, yes.
Yes.
Oh, good, good. So those fees have been in place since 2019 in preparation for that. The implementation of these disorders cannot happen very quickly. So there are a number of things that must be in place before actual testing can occur. And that is with procuring equipment and validation and education, etc. So that is why those fees have been in place since that time. And that is normally the route we do take in these instances.
Okay, that clarifies it for me. Thank you very much.
You're welcome.
Any other questions? Okay, guess we'll do a roll call vote.
Absolutely. Mr. Kreitzer? Mr. Kreitzer, I'm sorry, I missed that one.
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Harrison? Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller? Thank you. Dr. Puritz? Thank you. Ms. Ramos?
Yes.
Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Swartz?
Yes.
Thank you. And Ms. Whipple? Thank you. Madam Chair, there are 10 votes for the motion to adopt.
Okay, great, thank you. So if you look at your agenda, we're at the point where we can take a break. What we have left to discuss are non-regulatory action items, which is the Board of Health Annual Report and Plan for Wellbeing Update, and then any member reports and any other business. Do you all want to take a 10-minute break, or do you want to continue on?
I would propose we
Continue on, okay.
Others?
Others? Continue on, okay. We'll forge ahead. So the next item would be our Board of Health Annual Report and Plan for Wellbeing Update. Is that Heather doing that?
It is.
Yes, it is.
And we're pulling up
And-
the slide deck now. Give us one moment. And we are good to go, Heather.
Great. Good afternoon, once again, Madam Chair and members of the board. Today, I will be providing you with the update on the Virginia Plan for Wellbeing. If you could please progress the slide. Great. As you may remember from previous presentations to the board, Virginia's Plan for Wellbeing serves as the State Health Improvement Plan, or SHIP. The plan that Virginia has been working from was to cover years 2016 through 2020. This plan was informed by a state health assessment, or SHA, which was completed in 2015. In Virginia, as in many states, the SHA and SHIP are linked and part of a continuous process. In Virginia, we have identified and decided to use the Mobilizing for Action through Planning and Partnerships framework for the SHA and the SHIP. This framework was developed by the National Association of County and City Health Officials. With the expiration of the Plan for Wellbeing in 2020, it was time for Virginia to conduct the next 5-year state health assessment. Next slide, please. Assessing the health of the state and population is one of the 10 essential public health services. The process of conducting a state health assessment has 4 primary components: identifying and engaging system stakeholders, collecting and analyzing health status data, collecting and analyzing stakeholder and community input data, and then summarizing, presenting, and communicating findings. Next slide, please. VDH began this work in the fall of 2019 by convening a SHA-SHIP Advisory Council. This diverse group of stakeholders identified the list represented on this slide of guiding principles to support the development of both the SHA and the SHIP. It was also decided that there would be a very deliberate focus in this process on being equitable and just by applying a health equity lens to the development of both the SHA and the SHIP. Next slide, please. The Advisory Council and VDH staff work to review existing state health assessments to identify and finalize the data indicator list. Could you hit the enter button, please? Okay. VDH program staff and data stewards were involved with the collection of data and narratives. The maternal and child health program had just completed an extensive assessment, state-level assessment, which involved the collection of qualitative data through numerous focus groups and key informant interviews. This data was pulled into the development of the SHA. Multiple data presentations throughout the state had been planned to begin in March 2020. If you can hit enter once again, please. Great. And that left us at the stage of doing the data walks, which, as I mentioned, were planned for March of 2020. However, during this time period, the COVID-19 pandemic arrived. As it's been shared with the board previously, this halted work on this effort as staff and resources were directed to the COVID-19 response. Next slide, please. This brings us to where we are today with the current state of this process. There had been a vacancy in staffing to lead the SHA process. However, in April of 2021, Kalita Willoughby was hired to serve as the SHA SHIP manager to lead this process. With this, efforts to restart the creation of the SHA engaged. As you're well aware, and as we have heard in the Commissioner's report today, the COVID-19 pandemic significantly stressed public health systems in Virginia and throughout the country. Gaps in healthcare for underserved and vulnerable populations were exposed. This, combined with the disproportionate impact of COVID-19 on communities of color, significantly raised the awareness of the impact of systemic racism on health. As a result of these lessons learned during the pandemic, VDH re-examined the work initiated on the SHA pre-pandemic to ensure that the SHA would be an accurate reflection of health in Virginia. As a result, the membership of the Advisory Council has been expanded to include more diverse representation as well as geographic variety covering the entire state of Virginia. As part of the focus on equity and engaging underserved and underrepresented populations, the SHA will now highlight key populations of focus. These populations include LGBTQ individuals, youth, veterans, people living with disabilities, Virginians of color, and the refugee and immigrant population. Next slide, please. Data analysts and epidemiologists at VDH have adjusted the data indicators that will comprise the SHA based on lessons learned during COVID-19 and continued feedback from the expanded Advisory Council. Where available, data will be stratified by race, gender, income, or education level. A list of the data indicator categories is displayed on this slide. Next slide, please. This slide depicts the various sources from which qualitative data will be collected. I would like to draw your attention to the statewide survey. A marketing campaign will promote the online survey to communities and organizations statewide, as well as targeting the populations of focus. The survey will remain open for approximately 1 month to collect responses. We will provide the link to this survey to board staff to share with board members. It's the goal that the qualitative data collection will be completed by February 2022. Next slide, please. It's anticipated that the state health assessment will be completed in March 2022. We're very excited to announce that the SHA report will be published in an interactive online report format to facilitate usability and accessibility by stakeholders. The SHA will be using the Live Stories platform. This platform has previously been used with great success to report findings from the maternal and child health needs assessment that was conducted in 2019. The SHA Live Stories site is currently under construction. However, I have taken a series of screenshots to provide you with an overview of how the user will navigate the site. What you currently see listed or displayed on the slide would be the landing page. And this landing page displays various indicator categories and subcategories. Next slide, please. As you scroll down the home page, all of the categories and subcategories are visible to the user. Next slide, please. When a user selects a category of interest, a landing page with narrative is accessed. Next slide, please. Scrolling down this page presents the collected data for the specific data indicator. Next slide, please. Scrolling further down that page, the user can select specific localities to access data available for that particular locality. Next slide, please. With the completion of the SHA anticipated in March 2022, the Advisory Council will then begin to develop the State Health Improvement Plan through the selection and prioritization of improvement strategies. The current goal of completing the State Health Improvement Plan is slated for May 2022. Are there any questions?
Go ahead. You mentioned the survey. Can you explain further to whom the survey is directed? Who are you surveying? How will that be disseminated? What's your target?
The survey will be open to the general public. There will be a marketing campaign to promote that this survey is available, and we are looking for input. However, we will specifically target those populations of focus that were previously identified. So we will have very targeted outreach to obtain feedback from those groups, as well as conducting focus groups and key informant interviews. We will be sharing this survey link with all of our partners and stakeholders in programs across the agency for them to share with their contacts as a way of promoting this through various channels. And we are still in the process of finalizing what that marketing campaign and communication campaign will look like, and so are very open to any suggestions or ideas from the board.
I would only ask, I know you already are fully aware of this, but if you're talking about an online survey link, then of course there are those with barriers to using online links, visual barriers, language barriers, literacy barriers. So how will those be addressed?
So for our specific, while I can't at this point in time respond to all of these answers, the work of the survey is being currently tweaked and developed by the advisory council for those specific populations of focus. There, we will also be conducting in-person focus groups to help adjust for that. With the survey, we are also factoring in and very specifically looking at health literacy level. I know that was referenced earlier in today's meeting as being a important concern and consideration during any type of communication or information sharing. So that will very much be factored in. In terms of, we're looking at ways in which to provide the survey in multiple languages. That is still being investigated as well.
Thank you. Can I ask another question? And this is, forgive my ignorance. There'll be a qualitative component to all of this huge effort, and that there will be a quantitative analysis as well as you collect data. Several years ago, when I first got on the board, it was very striking to me, and you know, we've discussed this before, that the health districts did not have electronic medical records, and data collection was a real issue. The Virginia Department of Health has risen to meet these challenges always, but there has been much discussion of improving quantitative data analysis. Has the pandemic, have any of the funds that we have received been able to has any of that been applied to improving our electronic infrastructure?
Short answer is yes. Through the American Rescue Plan Act, ARPA, we have received a number of funds that will be directed towards our data analytics, data reporting, data visualization, both technology and workforce, because that's also a big issue. There's also significant funds that have been made available for doing the design for an electronic health record system for the health department. John Ringer actually is very involved in these ARPA projects. And I don't know, John, if you wanted to say anything in addition to what I just said about that.
The only thing I would add, Dr. Oliver, is that there are some other funds we've received through the ELC grant, the epidemiology and laboratory capacity grant, that are focused on exactly what you're speaking about, increasing, also adding to our data capacity on that side, and the technology of allowing us to use data better and that kind of stuff. So I think that's the only other place I would add where we have received significant funds, and it is going to make a difference in this area.
And Wendy, the other thing you should know is we set up several months ago now a Center for Public Health Informatics within the department, headed by Tim Powell. This is and he's now in the process. He's staffed it up, and it includes bringing in personnel to deal with all of these sort of issues around data modernization, right? So it's going to be very helpful. And included in that, for example, is the translation, transcreation aspect, accessibility issues that you raised around our web presence and so on.
Well, I applaud all of you, all of your leadership in this, and thank you.
So my concern would be, how are we going to make sure that responses to an online survey come from Virginians. I could see, I mean, there are some controversial health care issues, and I could see a survey getting a life of its own and having a lot of out-of-state responders. So is there a way to screen those who participate in the survey?
That is an excellent question. Other than asking for initial demographics, that would include a respondent's location within the state. I am not sure if there is a way through perhaps monitoring of IP addresses, if that is possible. I will take that back and share that and inquire about that. I do feel like that is a valid concern that you've raised.
Any other questions? Okay, thank you so much, Heather.
Thank you very much.
Madam Chair, we do need to take just a roll call vote on this and have a motion
Okay.
to adopt. Just wanted to make
Can I have a motion that we approve this report? All right, second? Second, okay. All right,
We'll do a roll call. Thank you. Mr. Kreitzer?
Yeah.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Harrison? Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller?
yes?
Thank you. Dr. Puritz? Thank you. Ms. Ramos? Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Swartz?
Yes.
Thank you. And Ms. Whipple? Thank you very much. There are 10 votes to approve the motion.
Wonderful, thank you so much. At this point, we are at our member reports. So I'll just start with Ms. Whipple and see if you have, we'll just go around the room. Oh, well, actually, should we start with those that are online? We could do that. See if anybody has a report.
We can absolutely do that. Would you like me to go down the list alphabetically and see who's here?
Okay.
All right. Mr. Kreitzer, do you have a report?
I have nothing to report today.
Thank you. Dr. Schuler, do you have a report?
No, ma'am, no report today.
Thank you much. Next up on here, Dr. Swartz, do you have a report?
Just wanted to mention briefly about Virginia pharmacists. We're continuing to support the Commonwealth's response to COVID. I'm not sure if all of you are aware, but pharmacists and pharmacies have administered a little bit less than half of all COVID vaccines in the Commonwealth. You might be surprised to know that the reason that we are able to administer COVID vaccinations is because of the Federal PrEP Act. We don't have the authority to independently order and administer vaccinations in Virginia code. So VPHA is going to be working this legislative session to kind of codify that, especially because when the Federal PrEP Act ends, we will lose our authority to go ahead and give vaccines. So we're looking to solidify that so people don't lose their point of access.
Thank you. And Madam Chair, I believe that is all of the members who are attending virtually.
Okay, okay, great. So Mary Margaret, do you have any? Okay. Ms. Ramos, anything to report? Okay. Me either. Jim?
Yes, ma'am. I'd like to use this time to provide a little history lesson that is appropriate after what happened in November, I think. You all might remember the abortion clinic regulatory upheavals that happened in 2011 and 2012. Legislation was passed. It was the famous legislation that included the infamous transvaginal ultrasound as a condition of getting an abortion. We were required to do some regulation based on the action of the legislatures. The intent of the administration at that time was basically to put an end to abortions in the Commonwealth. And the Attorney General took the lead, and he basically steamrolled us in a manner that I worry, I hope I'm wrong, might be tried again. There were regulations drafted under the oversight of the AG that included a number of changes. The most significant one related to the physical plants that were required. A national body issued guidelines for the architectural and other requirements associated with surgical centers, with ambulatory surgical centers. And the regulations required that abortion clinics were going to be required to meet those regulations immediately. That was going to be a major problem for most of these clinics. The board at a meeting, and I think I've got the dates right, in June of 2011, adopted regulations that for the most part were in line with what the AG had demanded. However, with respect to the physical plant, we adopted language that effectively grandfathered the clinics in a pattern that had existed in our regulatory structure since 1947. The new regulations would apply only if a clinic were to request major rehabilitation or a new facility. The AG did not accept our action, to put it bluntly. He sent a letter to all of us board members in the summer of 2011 saying that we had violated the law and that he would not represent us in the event we were sued, either as a board or as individuals. And it was the individual part that really scared a lot of board members. Suits were going to be inevitable, much passion associated with the entire question of the abortion clinics. And it mattered. It had a huge effect. At the next board meeting, and again, I think I've got the dates right, September of 2011, the board revisited the regulations and adopted the language proposed by the Attorney General. I think the number was 11-2. I think we had increased the number of board members at that time. In any event, Antigen and I were the only ones to vote against it. It was, fortunately, the language in the regs included the right of the commissioner to make waivers. And she made a number of such waivers, and her tenure did not continue all that much longer. However, I mean, the good news was, I think we had 21 or 22 clinics at the time that the regulations were adopted. I think the number shrunk to maybe 14, but in any event, abortions were still available in the state. I wrote a letter to the Virginia Bar Association because I had been advised by a professor at the University of Richmond who was an expert on the Virginia Administrative Procedures Act, whatever. That might not be the exact name, but it's close to it. And he said the language of the act was unequivocal, that the Attorney General had the right to represent us. Not the right, the obligation. And he didn't. He refused. He would have refused. A clear ethical violation. My letter to the Virginia Bar Association pointed this out, and of course that got me absolutely nowhere. The Bar Association was not about to take on the Attorney General. But all of this, I guess, and as I said, I hope it becomes unnecessary to consider, because the governor has said eliminating abortions is not the top of his agenda at this point. I'm not quite so sure, given the statements of the Attorney General-elect, that applies to him. But I'd like to get ahead of this at this time. If we as board members don't want to regulate women's health clinics in a manner that's acceptable to the new administration, then we don't need to do it. Regardless of what the AG, less likely the governor-elect, might say. We ought to follow our own practices relating to the implementation of regulations and stick to our guns. We have obligations that are apart to the obligations that might be the priorities of new elected officials. Sorry to take so long, but I thought that might be useful.
Thank you, Jim.
So whoever arranged for the OBGYN to sit next to Jim was very wise, since I can segue right onto those statements. That was actually my first interaction with the board as the chair for Virginia ACOG and testifying. And I think Wendy and I both got very involved at that point. So I would say that your recollection is spot on, and a good history lesson is always in order so that we don't repeat past mistakes or get cowed by formal looking letters. And I appreciate you reminding us that just like we don't want mandates for vaccines, and many people are behind that, but they would instead be for mandates of how women take care of themselves and what happens between a woman and a physician. And it's hard to hold both of those ideas in your mind and be honest to yourself that you're really preaching truth as opposed to just political expedience.
Well said. Elizabeth?
Hey, one thing to segue off of that, in terms of perhaps just maybe getting ahead of something that could happen. I don't know whether anybody knows what the governor-elect's position may be in terms of following in the footsteps, say, of DeSantis in Florida, in prohibiting private companies to mandating vaccinations among their employers. No sense at this point as to what he may do in that regard. However, I think it just bears thinking about, so that when and if such a thing does happen, we are prepared, and perhaps we have no power to do anything, but I think we need to think about it. That's not really a report, it's just a comment. Thank you.
Well, I would say, is there any other business to be brought? Anybody? Okay. Our next, any other discussion that anyone wants to entertain? Okay. Joe, when is our next meeting is in March? Is that correct?
It's March 31st.
Okay. And is that a Thursday? Again, or?
Yes, Madam Chair, all of the 2022 dates are set to be Thursdays.
Okay. All right. Well, if there is, I think he already did it. Yeah. Earlier. Do we need a motion to adjourn, or we don't? We do. Can we have a motion to adjourn? Okay, second. All right. All in favor? Aye.
Aye.
Okay. All opposed?
Aye.
All right. All right. Meeting is adjourned. Thank you very much, everyone. Safe travels home and wonderful holidays.